Good morning, good afternoon, and good evening, and welcome to the 9th Annual Symposium on Global Cancer Research. We are going to get started in just a moment. My name is Mishka Kolisira. I'm with the Center for Global Health at the U.S. National Cancer Institute. I'm going to walk through a couple of logistics before we get started. All of the attendees will remain muted throughout the event today and tomorrow. The symposium is being recorded, and the recording will be made available to all the registered attendees, registrants. If you are experiencing any audio or video issues, you can visit the Zoom link shared on this slide or send a text message to Confex Tech Support in the chat. We ask that you use the Q&A box at the bottom of your screen to submit questions throughout the symposium. And we invite you to join us on Twitter at NCI Global Health. We will be live tweeting throughout the event, and please use the hashtag ASGCR21. Without further ado, I would like to turn it over to our symposium host and member of the Scientific Steering Committee for this year's symposium, Dr. Mariam Mutebi of the Aga Khan University Hospital in Nairobi, Kenya, who will kick off our event. Over to you, Dr. Mutebi.
Thank you, Mishka. Good morning, good afternoon, good evening to you wherever you are. As Mr. Kolisira said, I'm a breast surgical oncologist at the Aga Khan University Hospital in Nairobi, Kenya, and I would like to welcome you to the 9th Annual Symposium for Global Cancer Research. Now, I think one would say perhaps as a result of the pandemic, we've all been forced to sort of hit the pause button and, take a step back and look at what is it exactly that we're doing, what are we hoping to achieve, and how can we perhaps do it better. And so in keeping with that, the symposium theme for the 2021 is Global Cancer Research and Control, looking back and charting a way forward. And this is, of course, in recognition of the fact, this is acknowledging the tremendous progress that we have made in cancer research. Yes, we have taken a hit with the pandemic, but I think there's incredible opportunities to do a lot more. And so in its 9th year, the annual symposium on global cancer research was the first satellite meeting in partnership with a consortium of universities for global health annual conference, and has consistently been the largest of the CUGH satellite meetings. Each year, the NCI partners with the NCI designated cancer centers who work globally but are located near the host city for the annual CUGH Global Health Conference. Both the 8th and 9th annual symposium on global cancer research, which were to be held in Washington, DC, and Houston, Texas, respectively, had to pivot to virtual events as a result of the COVID-19 pandemic. So as a result, this year's symposium is organized through a collaboration with the U.S. National Cancer Institute, Center for Global Health, the CUGH, Global Health, the CUGH, the Dan L. Duncan Comprehensive Cancer Center at Baylor College of Medicine, the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins University, the University of Texas MD Anderson Cancer Center, the American Society of Clinical Oncology, the American Association for Cancer Research, and the international collaborators of these institutes from the Ministry of Health in Mozambique, the Aga Khan University Hospital in Nairobi, Kenya, and the Tulane Health Officers for Latin America. We're incredibly grateful to the diverse array of speakers who will join us for this year's symposium, and we're all looking forward to learning from their presentations and engaging with them through the interactive Q&A and discussion segments. I'd encourage us all to sort of have the theme in mind and contribute as much as possible. Let's carry on this conversation to see how we can collectively move forward as an oncology community. We're going to kick off this year's symposium with 3 brilliant keynote addresses from 3 leaders in the field of oncology. First up is Dr. Norman Sharpless, who is the director of the U.S. National Cancer Institute, and he's going to speak about past global work of the National Cancer Institute and the National Cancer Program, and look a little, reflect a little on the future of global oncology research from through the lens of the NCI. Next up is Dr. Julie Grelo. Congratulations. She's now the new Chief Medical Officer of the American Society of Clinical Oncology. And she's going to talk a little about global oncology as an academic discipline and reflect on where she feels the field is going and what are the opportunities for growth in this area. And last but not least, we have Professor Cecil Lorenzi Ferreira, who is the head of the Cancer Control Program at the Ministry of Health in Mozambique. And she's going to introduce the conference theme and also give us share a little her insights on the sub-themes of resilience and equity in global oncology. Welcome.
Greetings from the National Cancer Institute. I'm happy to be with you for this 9th annual symposium on global cancer research. Improving global health is a top priority for the NIH and for the National Cancer Institute, and is an area of strong personal interest for me. As a medical student, I worked in the field in Santiago, Chile with the School of Public Health there. And as a medical resident, I actually worked in Guayaquil, Ecuador, in a hospital there. And as Cancer Center Director, I was very involved with the University of North Carolina's programs in Malawi, Southeast Asia, and South America. And so this is an area where I think the NCI has a lot of support to give and a lot of important equities. There have been many NCI-supported contributions to global cancer research and control over the last few decades. For example, the discovery of multi-agent chemotherapy as an effective treatment for Burkitt lymphoma occurred through collaborative studies in Uganda. There's the development and testing of an effective human papillomavirus vaccine through collaborative studies in Costa Rica. And we have continued optimization studies going on in Costa Rica for single-dose regimens. The National Cancer Institute has contributed to the development of machine learning-enabled smartphone algorithms to effectively and efficiently screen women for cervical neoplasia. And we participated in novel studies in the treatment and prevention of HIV-associated malignancies in Latin America and Africa, conducted by the AIDS Malignancy Consortium. The National Cancer Institute designated cancer centers have substantially expanded their portfolios of global oncology activities, with particular interest shown by early career faculty and trainees. This has been a really successful set of endeavors for the NCI over the last few years. We've supported global cancer research training for investigators in low and middle income countries through NCI-led programs and in partnership with the Fogarty Center. And we provided scientific expertise to policymakers and implementers engaged in global cancer control. We've done all of this through the current NCI Collaborating Center agreement with international stakeholders like the WHO. In that effort, NCI coordination of the International Cancer Control Partnership has been a really key effort. Many of these efforts have truly benefited people worldwide, proving that studying cancer everywhere benefits people everywhere. The creation of a dedicated Center for Global Health occurred in 2011, done by then NCI Director Harold Varmus, and really reflected the NCI commitment to play a leading role in international efforts to address cancer as a global public health problem, and to consolidate and coordinate our efforts and interactions with new partners. I'd say another important milestone for the center happened in 2020, when we were very fortunate to be able to recruit Dr. Satish Gopal to come to CGH as this new director. I've really enjoyed working with Satish, and he's brought a strong new vision to this role. Though the history of NCI global engagement predates the National Cancer Act of 1971, progress against cancer has been really remarkable in terms of the acceleration since that legislation. This year, the National Cancer Institute is joining with partners across the cancer research community globally to commemorate both the progress that has been made since that time, but also to acknowledge the formidable challenges that still remain before us. We should acknowledge that this progress that we've seen over the last 5 decades has not been equitably delivered to all people everywhere, including many communities in the United States and internationally. Major opportunities exist to develop new tools and technologies that overcome key barriers in cancer control for historically excluded communities worldwide. Some of these might even represent improvements over currently available approaches that have become entrenched in high-resource settings. So an example of this is going straight to self-collected human papillomavirus testing as a replacement for cervical cytology clinics. In other cases, existing tools and technologies may be adequate, but they're not applied evenly. And opportunities here exist to study the population-level translation of cancer control interventions to ensure that progress is made across the entire population in decades to come. It is reassuring to know how supportive the new administration is for the work we do at the National Cancer Institute and for all the work you do in cancer control and cancer research and cancer science. President Biden made his support clear on World Cancer Day last February 4th when he said that the fight against cancer will be a major area of focus for his entire administration. And he added, and I quote, "On this World Cancer Day, I want every family facing this fight to know this: there is hope," end quote. NCI will continue to prioritize global cancer research and control by supporting innovative and impactful research, by supporting global cancer research training, by promoting the integration of scientific knowledge into global cancer control, and by partnering with individuals and organizations like all of you here today to remain responsive to global cancer needs and build a brighter future for all. Thank you for your time and attention, and I hope you have a terrific meeting.
Welcome to the 9th Annual Symposium on Global Cancer Research. I'm Julie Grelo, the new Chief Medical Officer for the American Society of Clinical Oncology. I'm going to say a few words on global oncology as an academic discipline. Global oncology has only recently emerged as an academic discipline. In response to the rise in cancer incidence and mortality rates in low and middle income countries and the increasingly global profile of ASCO's membership, in 2014, the ASCO board appointed a Global Oncology Leadership Task Force to provide recommendations on ASCO's engagement in global oncology. The first recommendation from this report was to promote the recognition of global oncology as an academic field. And as was stated in the publication, working with various stakeholders, ASCO could serve a role in transitioning global oncology from an informal field of largely voluntary activity to a more formal field with a strong research component and recognized value to oncology training and the practice of oncology. As a consequence of that recommendation, in 2017, the ASCO Academic Global Oncology Task Force was formed, and they were tasked with making recommendations to guide ASCO's contributions toward formalizing the field of global oncology. The resulting recommendations were categorized into 4 main areas: training, research and practice, professional development, and then some overall recommendations to conclude. Those recommendations in the bucket of global oncology training included to promote the awareness of global oncology and the inclusion of global oncology opportunities within hematology oncology training programs, to partner with other oncology subspecialty societies as well as other review committees of the ACGME, to outline global oncology competencies, and to create a repository of global oncology training opportunities and resources. Under the topic of research and practice, the recommendations were to advocate for global oncology research, to seek bridge funding for global oncology research, to enhance the dissemination of global oncology research, and to promote equitable collaborations between researchers in higher resource and low and middle resource settings. Within professional development, the ASCO Academic Global Oncology Task Force recommendations included that ASCO should serve as the professional home for the global oncology community, networking opportunities being provided, mentoring, and to serve as a repository for career opportunities. It was also recommended that ASCO should consider recognition for leaders in global oncology. And some summary recommendations included leveraging ASCO international programming, partnering with other oncology societies, and engaging with the USNCI, the NCI Center for Global Health, and the Fogarty Center. What are the critical components for sustainable success in building this global oncology field? Well, first, we need to be able to demonstrate benefit to oncology training programs and academic centers for supporting training in global oncology and specialization in academic global oncology as a career pathway. We're also going to need to be able to validate to funders of the necessity and the value of supporting well-structured, evidence-focused research that's going to be able to lead to improvements in cancer outcomes globally. We'll need to establish strong partnerships with international healthcare providers and governments, patient advocates, governmental agencies, private philanthropic foundations, other professional organizations, as well as the business and corporate sector. And we're going to have to promote responsibility in all of our projects and partnerships. We need to leverage existing infrastructure and relationships, collaborate when reasonable and possible, respect international partners in terms of shared authorship, funding, and opportunities for their own career advancement. What role can we all play to help with global oncology as an academic discipline? We're going to need to train experts who can think critically about innovative solutions to global cancer care and control, and provide them with the tools and the support to conduct research as well as implement change. Collaboration across all sectors of the global health and oncology communities is going to be required to realize the vision of equity and improved cancer outcomes worldwide. Thank you.
Dear colleagues, it is with great pleasure and honor that I accepted the invitation for providing these open remarks to the 19th Annual Symposium on Global Cancer Research, which this year is dedicated to global cancer research and control, looking back and charting a path forward. As I look back to what have been the key components of improving cancer control and research in Mozambique, as we developed the first National Cancer Control Plan of Mozambique, launched in 2019, I would like to list a few lessons learned in the process. Education is key. The need to educate the public, the government, and the healthcare providers about the importance of cancer control so that we can prevent unnecessary death and suffering in our country among our families. Cancer does not have to be a death sentence, which is how people living in low and middle income countries see this disease. In Mozambique, cervical cancer, a preventable and treatable cancer, kills more women than any other cancer, but effective prevention and treatment strategies are possible, and we have been making progress in their implementation in our country. For that purpose, we count on the support we get from our partnership and active collaboration in cancer research and control with our external partner. Because of a lack of infrastructures and human resources, such as specialists dedicated to cancer research or to cancer prevention and treatment, this partnership, engagement in research and collaboration to design and implement a program for cancer control are vital to ensure the resilience of our program, increasing the pool of resources and infrastructure available while providing assistance when most needed. The crucial knowledge exchange between partners that happen during this engagement allows for the inclusion of ideas and priorities that are important for both parties, leading to collaboration opportunities that move, include, and improve the quality of exchange as we go forward. As the global cancer community, thinking about how we can continue to make progress, charting the path forward for global cancer research and control, some suggestions included: to build a model cancer of excellence in cancer treatment and research around the world, to build strong partnership that can help identify financial assistance and increase the resilience of cancer research and control in low and middle income countries, to develop and implement cancer control plans driven by priorities and reality of each country. To establish and strengthen cancer registry and similar health data system for cancer control, to ensure access to essential medicine for cancer care, and to ensure access to safe radiation treatment. In addition, government must make deliberate effort as part of the cancer control planning exercise to training and equip adequate number of professionals that can support adequate cancer care. I thank you again for the opportunity and look forward to the ideas and exchange about how we can continue working together to improve cancer control outcome for all. Thank you all.
Wow, I think that was brilliant. I think I would like to thank our three keynote speakers for those incredible insights and for really setting the stage for our subsequent deliberations. You may have noticed that throughout the talks, there's been a common theme around collaboration and strong partnerships. And I think perhaps one of the key attributes of these strong partnerships and collaborations is resilience. And looking at how do we effectively create sort of bounce back or elasticity in the systems such that irrespective of whatever else is going on in the world, we're able to forge forward in our efforts towards cancer care, improving cancer care and control. And so as part of the events for the day, we are having a resilience panel that's going to address building towards resilience in cancer care, control and research. We do have an oral abstract rapid fire session at the end. Lots of incredible abstracts, lots of insights from very keen researchers. You don't want to miss that. But the next bit is going to be the resilience panel, and I'm going to turn over to the panel to Dr. Anne Rossich, who's an associate professor from the Department of Epidemiology at the Johns Hopkins Bloomberg School of Public Health, and Sidney Kimmel Comprehensive Cancer Center to lead us through the next panel. Dr. Rossich, welcome.
Thank you. Thank you, Dr. Mutebe. I'd like to wish everybody a good morning, good afternoon, and good evening. As Dr. Mutebe said, I'm Anne Rossich, and I am going to facilitate this panel. So on behalf of the Scientific Committee, I'm pleased to welcome you to this first session, Building Towards Resilience in Cancer Care, Control and Research. And I want to first start briefly with a little bit of background on this panel. It obviously was developed during a really challenging time, as a lot of our first speakers commented on. So this panel is going to focus on critical gaps that have emerged in the face of acute threats and emergencies. Obviously, for most of us, the COVID-19 pandemic is the first thing that comes to mind, but there are other epidemics, natural disasters, political turnover and turmoil, and unfortunately, the list goes on. So during this panel, we're going to look at what it will take to build systems for global cancer research, prevention, and control that can continue to function during these hardships. The panel will provide a framework for thinking about the concept of health systems resilience, and we'll consider the critical issues around this topic. After an introductory lecture by a global health expert in strengthening health systems, we're going to then move on to some specific solutions-based case studies, which will focus on developing and implementing health emergency and risk management strategies, strengthening primary care, evidence-based decision-making and clinical strategies to ensure the continuum of cancer care, and the role of leadership in policy dissemination and implementation of strategies to build resilience in cancer care research and control. All of our panelists are global health experts, and they each provide really different perspectives on the impact of the pandemic and other threats to resilience. But more broadly, right, they're really going to focus on bouncing back better, as one of our speakers so perfectly expressed it. Before we jump into their talks, we want to hear from all of you, all of our attendees. And so the question that we're going to pose to you is, what does health systems resilience mean to you? right? So from your role in this field of global cancer, from your country, maybe even from your own personal experiences in healthcare. In order to facilitate this, we're going to use an internet system called Menti. If you can open your web browser and go to www.menti.com, as it shows on the top of the slide. When you're there, enter the code 43405668. A little box is going to then appear where you can enter your answers, right? So this is just to get everybody thinking. I don't think it is a concept that we necessarily have formalized in our field or sort of on a daily basis. Okay. So please put your feelings up there, your thoughts, your experiences before we dive in. What does health systems resilience mean? I see sustainability, good governance, absolutely. Consistency, continuity, handling threats and challenges. Great. Ability to adjust to the unexpected solution and unexpected situations. Flexibility. Yeah, absolutely. Others, effectiveness, again, sustainability, safe to all. Robustness, absolutely. There we go. Again, we're seeing sustainability, strong networks and clear communication. Agree, the foundation of everything we do. Strong primary care networks, persistence, good governance ×2. Ability to get minimally needed care in case of emergencies, absolutely. Continuity of care. Flexible, rapid solutions, adjusting and remaining effective. Adaptability. Don't let setbacks stop you, right? That persistence and perseverance, thank you. Committed staff, well-funded. Elasticity, good governance. Ability to make sense of what happens to a health system over time and to adapt accordingly. Not giving up on collaborators, patience with delays. Timely, appropriate, and affordable response. Yeah, these are great. We struggled really thinking about it. So you guys are certainly responding much quicker and I think better than I had. Okay, great. All right, we're going to close this in just one more minute. Okay. We'll loop back to some of these. Our speakers will absolutely touch on these sort of from their own perspectives, hopefully giving some framework to these ideas and giving concrete, tangible solutions for how we might emerge stronger and better, prepared for the next. Unfortunately, we'll continue to endure threats to health system and care. Great. Quality and sustainable health. Persistence, apolitical, absolutely. Elasticity, timely response, not relying on external funding. Absolutely, that's a great point, right? Massive shifts or ends of funding can really be a threat to our health systems in many low to middle income countries. Effective in giving the patient the first priority. Yep. Thank you for the patient focus there. Okay. Great. We're going to close this Menti session so that we can turn it over to our first panelist. What I will just say is that before I introduce this panelist, again, like Dr. Mutebe, I want to encourage you to use the Q&A function that's at the bottom of your screen. We will, at the end of all of our speakers from this session, we're going to have an open Q&A session. So please type those questions as you go along. So with that, I would like to introduce our first speaker. It is Dr. Rifat Atoun. He is a professor of global health systems at Harvard University. He's going to give our introductory lecture to sort of lay a foundation for building resilience. We know that COVID-19 has impacted all areas of life, and cancer is no different. We're experiencing profound health systems challenges related to screening and diagnosis of cancer that could have impacts on morbidity and mortality for years to come. However, as our speaker will point out, with innovations and creative approaches, we really have the opportunity to improve how cancer care is delivered by building resilient health systems. Dr. Atoun is going to provide us with an introduction to resilience and a framework for building core capabilities for resilience. And with that, I would like to turn it over to Dr. Rifat Atoun.
Good morning. I'm Dr. Rifat Atoun. I'm Professor of Global Health Systems at Harvard University. It's a real pleasure to contribute to the National Cancer Institute's annual symposium on global health research. My presentation is going to focus on health system resilience, and we'll explore implications for cancer research, treatment, and care. So COVID-19 has had a major adverse impact on cancer care with reduced screening, diagnosis, and access to cancer care, leading to many individuals foregoing cancer care, many delaying access to care, and many who are able to access care receiving suboptimal care and services. This has led to an increase in the number of undiagnosed cases, with many late-stage cases presenting to health systems, with consequent rise in morbidity, deaths, and massive rise in cost. In order to effectively manage COVID-19 and other major health threats and effectively continue to provide cancer services, one needs to develop health system resilience. This requires a set of core capabilities, which I call with the acronym FIPRAD. First is foresight, anticipating risks and potential threats. Second is intelligence, monitoring for early recognition of threats. Third is preparedness, systems for communicating and mounting a coordinated response. Fourth is responsiveness, an ability to rapidly react and respond to events as they arise. The fifth is critically important, agility. This is adaptive capacity of health systems to respond flexibly and adjust responses to maintain system functionality as the threat hits the health systems. And finally, durability. This requires learning and system redesign to establish a new equilibrium as the threat impacts on the system and test systems capabilities. But COVID-19 has accelerated use of innovations in health systems. We're seeing use of new diagnostics and digital solutions for tracking and tracing with targeted interventions. We're seeing use of big data and analytics with application of machine learning and artificial intelligence, increasing use of conversational agents with chatbots or chatbots supported by AI, remote diagnosis and care. We're seeing increasing use of wearables and use of smart mobile phone sensors to provide real-time data and analytics. So COVID-19 has enabled the acceleration of these innovations. What we're also seeing is an innovation in a number of processes in relation to cancer care. For example, in the UK and Italy, we've seen establishment of cancer hubs to provide safe services for patients. We've seen in many countries emergence of virtual care with virtual consultations, remote off-site diagnostic testing, establishment of virtual tumor boards, optimization of the intervention mix, taking into account the constraints, and innovations in care delivery, such as delivery of treatment to patients at home. What we're also seeing is a change in guidelines on cancer care to taking into account the new reality. For example, in the UK, the National Institute of Health and Clinical Excellence has produced new guidelines for cancer care. In Europe, in the US, we are seeing similar approaches. We've seen, again, adjustment and adaptation of guidelines on treatment regimens in UK, in Europe, in US, and beyond. And finally, we're seeing innovations in relation to clinical trials. The US Food and Drugs Administration, in Europe, the European Medicine Agency, in the UK, MHRA, and several other countries have enabled faster registration, faster trial approval, remote consultations, online recruitment of patients to trials, flexibility of protocol deviations and trial design, and flexibilities around data publishing. What is very important in relation to this capacity for resilience, as well as the innovations to cope with major health threats, the importance of universal health coverage, which we've demonstrated in a paper published in The Lancet a few years ago, the effect of economic downturns on cancer mortality. we were able to show the adverse consequence of economic downturns on cancer mortality with excess deaths, but we were able to show that universal health coverage has a protective effect. Countries that had universal health coverage was able to prevent the number of excess deaths compared to countries that did not have universal health coverage. So putting all this together, building resilience for major health threats requires for cancer maintaining and extending innovative approaches to cancer prevention, care, and control, as well as innovations in registration, management of clinical trials, investment in comprehensive scale-up of interventions for cancer care to harness synergies that exist, strengthening health systems during a response, and adapting the response to the changing reality. And finally, investing in universal health coverage, which has a protective effect. Thank you very much for your attention.
Thank you, Dr. Atun. An actual special thank you, actually. I was really excited when you agreed to be a part of this panel, and I would just sort of add, since I won't have the chance to read long bios for our speakers, but they have a really impressive list of accolades and experiences. So I think this is where Google will be your friend. And we're happy to share more information of our speakers, and they're also on our conference webpage. There's a nice bio of each speaker. So building on these opportunities, our next speaker, Dr. David Peters, who is the chair of the Department of International Health at Johns Hopkins Bloomberg School of Health, joins us to highlight the important role of communities, of partners, and multi-sectorial groups in response to a crisis by looking at case studies from the Ebola crisis in West Africa and emergency and disaster management more generally. He'll highlight the importance of a comprehensive and community-based approach and presents models for our consideration as a global cancer community. So with that, I'd like to introduce Dr. David Peters.
Hello, I'm David Peters. I'm professor in the Department of International Health at the Johns Hopkins Bloomberg School of Public Health. And today I'm going to be talking about the role of communities in health systems resilience. I'm going to be talking from the perspective of health systems in low and middle income countries, where often the problem is that you have very low performing health systems. So the interest in resilience is not just about bouncing back to a low performing equilibrium, but really about bouncing back better. I'd like to start with the case of the West African Ebola outbreak that had a tragic effect on nearly 30,000 cases and over 11,000 deaths in West Africa. Recognizing it wasn't just a viral epidemic, but it quickly became an epidemic of fear, rumor, and misinformation. And that quickly led to a series of vicious cycles in the collapse of the healthcare service delivery, as well as loss of social capital and community cohesion, as well as a huge economic collapse with problems in labor force, agricultural productivity, and income and trade being severely stressed and unstable. Really critical to how the Ebola outbreak was handled was the central role of communities. Here you see a picture of a riot early in the Ebola outbreak in Monrovia, Liberia. And really what you found was a lack of trust and engagement with the community at the beginning of the epidemic that led to murders of healthcare workers, the riots, as well as lack of cooperation. Now, there's good reason for that lack of trust. There's a long history of exploitation and unethical medical research. One dimension is the history, as you can see, the extractive map of Africa of the kinds of resources that have been extracted by foreign powers, but also a long history of unethical medical research that you can see the headline drawing attention to that. So there are already large community suspicions even before the outbreak began. Now, what turned it around? If you look at what's published in the New England Journal of Medicine or the Lancet, you really see a focus on the United Nations mission, the start of ETU, the Ebola treatment centers, and patient isolation. But it's not really clear that that was sufficient or even the main thing. This is a the picture of Liberia, the case profile of cases per day in 2014. And the bottom is the now familiar type of reproduction number, where you want to get the reproduction number below 1 to be showing that you're turning the outbreak around. Now, what you can see is that by the time UNMIR came and the ETUs were built, that was well after the reproduction number was below 1, which was towards the end of third week of September. And many of the later Ebola treatment units that were built were in fact never used. So really, there are other factors other than these external forces in turning it around. And clearly part of it was national and local leadership. The workforce was predominantly local, and you had strong political leadership, particularly in Liberia, I would say. There's a huge role of community engagement to change people's behavior, to reduce exposure, to get treatment, and to have communications from local messengers about which action to take. There was a linking of community engagement as well as the clinical care with the lab and the public health that was really then combined with some aggressive public health measures. Now, what happened organizationally was the building of an incident management system, an emergency operations center. And here you can see a picture of that. It was really built on the fly in Liberia during the outbreak. Now, what also happened was they had to learn from their riots and learn from their mistakes. And so they quickly added issues or teams around community mobilization and psychosocial support. As we continued to work in Liberia during the long tail of the epidemic, we really looked at this role of community resilience and how important it was. One of the findings was that there was really a lot of commonality of the community response to Ebola, as during the long decades of war and civil strife in Liberia, with issues around distrust, fear, and psychological trauma. But really the community cohesion was key. It helped people to understand the threat and unite as a community during Ebola, as well as being able to take care of each other during the phases of the war. And of course, it's much more complicated than that. But the message really is about, you need to not just build physical infrastructure and technical capabilities, you need to build leadership and social capital to strengthen bonds in communities and trust across actors of the health system. I'd like to also look more broadly about how do you build resilience through health emergency and disaster risk management, not just from infectious diseases, but from other natural disasters. One of the things we did was to try to document the costs of health emergencies disasters. The most easily traceable is really the direct costs from large disasters. You can see here on the right, the growing climate-related events, and as well as geophysical events. So the climate events are like storms, floods, fires. That's about $170 billion a year. The social cost of disaster has always been measured at higher than, but here conservatively measured at 170 billion. When you add smaller disasters and pandemics, you can easily get to $500 billion a year of costs. Now, what do you need to invest in these common goods? You do actually have to go beyond hospital and clinical care. There are the set of population functions that need collective arrangements and financing because they're public goods and large social externalities. So we costed out these what it takes to put policies, taxes, communication, and population services like disease surveillance and response together. And we found that globally, it's about $5 per capita, and total year of capital and recurring costs is about $26 billion globally. That's about 1/20th the cost of the cost of conservative estimate of disasters in any given year. Now, how do you do it? Now, we talked about the kinds of multi-agency coordination, and it's also multi-sectoral coordination that's needed. You need to work across functions or sectors. It's not just health ministries. You need to work across hierarchical units from local to national and geographic divisions, whether they be political or health catchment areas, to different kinds of organizations like hospitals and regulatory bodies and civil society organizations. The problem is it's very difficult to do, and particularly in federal states where, here's the case of India, they describe it as a sprawling organizational diagram across an array of agencies with unsound decentralization, overlapping and incomplete responsibilities, disconnected to financing ability. Basically, any large state has this kind of problems, particularly federal states. It's also important to recognize that you can't just look at one aspect of the problem. So here you look at in emergencies, from the hazard to the exposures to the vulnerability, and the full cycle from prevention, mitigation, preparedness, response, and recovery. So just looking at, say, prevention or treatment is just not enough. You really need to look at a coherent set of issues. And you need to do it with the types of adaptable institutions in order to approach it. You certainly need all of state into institutions across sectors with technical learning that we know a lot about, but also about social learning that involves stakeholders in communities, civil society, and business, really all of society, to strengthen those organizations to be able to address these kind of complex issues. So in conclusion, there's really many roles for community engagement in these kinds of arrangements. You need to engage them in the design of the program to be able to listen and respect opinions of those affected, understand issues of trust and learning, include community members in not just the planning, but also the responses. Make sure you know who is excluded because they're often most at risk, and being able to build those technical capabilities and institutions, focusing on what can be done. So with that, I'll end the talk about community engagement. Thank you very much.
Great, thank you so much to Dr. Peters. I think for me, one of the things that I really appreciate about his remarks is that it pulls us out of this exact pandemic, that it pulls us out of sort of our narrow cancer focus, right? So that we're really looking at systems approaches and recognizing that we in cancer are part of a complex system that has many competing health priorities, and solutions will need to be in line with that, right? So common goods and partnerships that are outside of our silo and that look at the system all the way from our community up to our tertiary facilities. I think related to that, an essential element, right, of addressing the overall system resilience that both Drs. Atun and Peters have discussed, primary health infrastructure needs to be strengthened so our systems don't rely always on higher level facilities for these basic but essential health services. Dr. Carla Unger Saldana from the National Cancer Institute of Mexico will elaborate on the importance of primary care in cancer and also provide us with a concrete case study of breast cancer diagnosis to show how primary health infrastructure can build our ability to tackle this cancer and many other cancers. Dr. Unger Saldana.
Good morning, good afternoon, good evening. I will be speaking about the importance of strengthening primary care for cancer control. I organized this presentation as follows. First, I will speak a little bit about primary care's role in health system resilience, and then immediately go to speaking about the relevance of primary care specifically for cancer control. And then I will be giving example of the consequences of failed primary care services and how these end up with breast cancer diagnostic delays. Okay, so primary care is considered to be the cornerstone of sustainable health systems in order to achieve universal health coverage and also for the health-related sustainable development goals. There is abundant evidence that health systems based on strong primary care services have better population health outcomes, increased public satisfaction, and are less expensive. Specifically for cancer care, primary care has a role along the entire cancer care continuum, from pre-cancer care through prevention and screening, all along the diagnostic pathway, the referrals that have to be done, and request of tests for diagnosis to be confirmed. And then after treatment, managing side effects and the entire survivorship healthcare plan, and also palliative care. Now, I want to focus a bit more on this specific role, which is early detection. So primary care physicians are the gatekeepers to the health system. If they fail, then the patient cannot go along this ideal pathway to confirm diagnosis in a timely fashion. So let me just make a brief pause to differentiate between screening and early diagnosis, which are very commonly used interchangeably, but are not actually the same thing. So there are two different ways of doing early detection. So whereas screening is focused on apparently healthy population that are not presenting any symptoms, and they get a test done to try to detect pre-invasive cancer, ideally, or at least invasive cancer that is still not symptomatic. Early diagnosis focuses on diagnosing symptomatic patients, but the idea is to diagnose them as early as possible after symptom onset has happened, so that clinical stage is early and the chances of survival are high. Now, early diagnosis is a key, primary care is key in early cancer diagnosis. 85% of cancer patients present through symptoms, and these all come through primary care or through the physicians that people seek care for the first time. So let me give you now the example of how these failures in primary care may result in terrible delays. And I'm going to use the example of breast cancer. So as we all know, cancer survival depends on two basic components. One is the clinical stage at which the patient is diagnosed. As we all know, the more localized the disease is diagnosed, the better the chances for survival. But what is very nicely represented in this graph is that not only is clinical stage very important, but within each clinical stage, we see differences according to the development of the health system that are being compared here. And we see how less developed health systems do much worse in terms of survival. And what do we mean by less developed health systems? We mean this kind of thing. Here I'm comparing health system intervals, that is the time between the first medical consultation and treatment start, between developed countries that have strong primary care services like Germany, Canada, or France. And you can observe here that patients start treatment in less than a month time after they first consulted a doctor. And if we compare with these Latin American and African countries, we see delays that are between 4 and 7 times longer. Time intervals for breast cancer in Mexico have shown to have a median of 7 months. 7 months between the patient detection and treatment start. And what is most relevant of this figure, which I want to highlight, is that the longest interval is that occurs between the first consultation and the diagnostic confirmation, which is known as the diagnostic interval. And more, there is evidence in low and middle income countries that it's not the patient's postponement of care, the main factor contributing to delays, but it's health system barriers that are not facilitating access to the health systems and diagnostic workup. So what goes on in this diagnostic interval? It's actually a quite complex process where patients need different tests, which are usually provided at different levels of the healthcare system. So it's no easy task. But I wanted to highlight here that this apparently little component in this complicated pathway is actually key, because as you can see, this is where the patient enters the system. And this is, again, the gatekeeping role that primary care plays here. So this is the primary care service giving access and studying the patient so that it can start treatment soon, or saying, no, you don't have anything, don't worry about it, you can keep on with your normal life. And so to end, I want to end with this positive note, recognizing this renewed commitment that has been done in the Declaration of Astana to build sustainable primary health care, which has these characteristics. And I want to highlight this last characteristic that they mention, which is primary health care that enhances health systems resilience. We need to provide primary care physicians with a whole system that supports their job by valuing the work that they do, by training them, and by giving them the systematic support, the system support, excuse me, to be able to establish diagnosis in a timely fashion and referrals in a timely fashion so that patients can benefit from earlier diagnosis and treatment. Well, thank you, and I look forward to our discussion.
Thank you, Dr. Unger Saldana. As she just highlighted, primary care is only effective for our patients when there is also a system in place to facilitate the entire continuum of care across what is often very hierarchical health systems. Our next speaker will share key innovations that Partners in Health and the Ministry of Health in Rwanda implemented to maintain the clinical continuum of care during COVID-19. Dr. Cyprien Chiambere, who is the Director of Oncology Program for Partners in Health in Rwanda, will be our next speaker. And he will outline how partnerships, adaptation, and innovation, along with a strong health system, really helped Rwanda address health disruptions during the COVID-19 pandemic. So with that, I'd like to introduce Dr. Cyprien Chiambere.
Good morning, good afternoon, everyone. My name is Dr. Cyprien Chiambere. I'm the Oncology Program Director. I work for Partners in Health in Rwanda. Partners in Health is a non-profit organization which is working with the Ministry of Health for healthcare strengthening and in providing cancer care. Many thanks to Anne and the program organizers for giving me this opportunity to be on this panel. I will be sharing our experience on how COVID-19 affected a continuum of care for cancer patients and how we were able to put it in mechanism in place to continue the cancer care. Rwanda is located in East Africa. It is a low-income country. It has a population of over 12 million people, with a life expectancy at birth of over 70 years and a GDP per capita of $748. Cancer treatment is provided in different hospitals, including the Butalo Cancer Center, which is in northern Rwanda and which is supported largely by Partners in Health. Rwanda, like other countries, was affected by the pandemic, and the first case of COVID-19 was registered in March 14. And a week later, the country went into a national lockdown, which immediately led to cessation of key services like public transport, leading to limitation for patient access to healthcare facilities. As you all know, interruption or delay in cancer care lead to disease progression and poor health outcome, including death. Here is a daily report that we get from the Rwanda Biomedical Center, which is showing that over 1 million of COVID tests done, we have registered 18,000 cases of COVID with a case fatality rate of 1.3%. The goal of my presentation would be to describe key approaches that were taken by partners in health with the support of the Ministry of Health and the other partners to navigate gaps in healthcare delivery arising from COVID-19 related interruptions and the lessons that we have learned. When the COVID-19 arrived and the country went into lockdown, some questions came in our mind, and we were wondering what we're going to do for our patients to continue care in this very difficult and unprecedented situation. So we had to come up with innovations and strategies, and here I will be describing some of our key interventions, like the setup of a drone-based drug delivery system, a quick establishment of a chemotherapy infusion center in the Kigali capital city, where there was the epicenter of the disease, and the setup of free transportation system for our patient who had to come to the center to receive IV chemotherapy and radiation therapy from their home and to the treatment centers and back home, as well as some social support packages. Zipline, most of you know the Zipline, which is a non-profit organization. It has been working with the government of Rwanda since 2016 with the main goal to improve access to blood products. So we relied on our strong collaboration with the Ministry of Health to approach Zipline, and we managed to negotiate, and 150 patients received oral medication through drones. Before sending the drugs with drones, a partners in health staff was appointed to confirm, first of all, if the patient were doing well, and to set up if they can do some laboratory at the nearest hospitals, and after all, to confirm if the patient has received the medication. Here is a nurse who was delivering a package of oral cancer drugs to a patient in a remote area of Rwanda. Other intervention were to come up with a transportation system to go and pick patients from their home. We were able to do this because we had patient data in our electronic medical records, and we had even their contact information. For those where information were missing, we used the community healthcare workers, which have a network over the country, to contact our patients. And we worked with the national police to secure travel clearance for our cars to be able to travel in the lockdown. And over 950 cancer patients were able to be transported to the center to receive their treatment. This is one of our nurses who were in a remote country, a remote place in the country, to bring the patient to the treatment center. In addition to this, we were able to accommodate all these patients who came to the center, and we were able to distribute some food packages and cash transfer for our patients to continue to survive in these difficult situations, because some of them were not able to do any income generating activity. And our psychologists were ready to provide support. What are the lessons learned in this pandemic? We learned that in a pandemic, the partners who are supporting the government have to be flexible and be able to adapt their intervention, their investment according to the priorities. You need to leverage the technologies, whether this means electronic medical records, whether this means drones, whether this means telephone consultation. We're able to do this because of our multi-sectorial, because of our patient-centered approach and multi-sectorial collaboration. And very important, is because of the existing strong national health system. Here is the challenges we encountered, and I thank you for your attention, and I'm happy to take any question you might have. Thank you very much.
Great. Thank you, Dr. Chambray. Any program that includes the use of drones is clearly pushing forward innovation to improve cancer care. But really, I think the comprehensive approach that included social support is a model for all of us and really commendable. So thanks for sharing your experiences, both the successes and the challenges. I think we always need to be able to discuss both sides. So thank you to Dr. Chambray. That was very cool. Now we'll have our last talk. And so I just want to do one final prompt that if you have any questions, please put those in the Q&A function, since we will have our open discussion after this last talk. So Dr. Sharon Campomway is the Assistant Director of Cancer Control in the Ministry of Health in Zambia. And she will revisit what resilience means, how vulnerable health systems create risk in the face of threats and emergencies. And she'll highlight how the Zambian Ministry of Health reimagined cancer control during the current pandemic, utilizing their national cancer control strategy, virtual platforms, and convening all of the powers that be to address budget constraints, supply issues, and so on. So I think just a really nice talk coming at it from a leadership and policy perspective to round out our panel on how we might move forward to build resilient health systems. So with that, Dr. Campomway, welcome.
Very good day to you all, and welcome to this panel. My name is Dr. Sharon Campomway. I am working as Assistant Director in the Ministry of Health here in Zambia, Assistant Director for the Cancer Control Unit. I sincerely want to thank you, the organizers of this meeting, for according me an opportunity to share a few highlights on the role of leadership in policy, dissemination, and implementation to build resilient health systems for cancer. Thank you so much for this opportunity. I know that previous presenters might have touched definitely on defining what a resilient system is. I just wanted us to look at some keywords that I want to point to. Resilient health system talks about integrated system, a system that is able to strengthen the human health and wellness. And it also talks about a system that has the ability to detect and interpret local warnings and quickly mobilize internally to absorb the shocks. A system that is able to isolate the threats. And when this is done, finally, it's a system that can be able to transform itself to adapt to these shocks, and a system that innovates new ways of doing business so that it can maintain its core function. And you know that in the health system, this is what we're talking about. I think before I talk about the role of leadership, I really just wanted to go through to discuss prior to COVID pandemic, what was happening in our systems, particularly coming from developing nation and in a developing world. We know that our systems were already vulnerable in that we were and are still grappling with high maternal mortality, communicable disease burden of HIV, TB, malaria, and 5 mortality, which is high. And we have a dual burden of disease, as we have seen an increase, a rise in non-communicable diseases. And Africa, a continent that I'm best on, has the highest death rates from HIV and AIDS and malaria, but also that it experiences the lowest life expectancy compared to other regions. So this is where we're coming from, a vulnerable system, but we are making progress. And we know that, in the progress that we're making, we know that we've had the Millennium Declaration at high global level of the Millennium Development Goals. Then we went into the Sustainable Development Goals, which we're currently in. And from 2000, we've been making some steady progress as Africa. We've seen a fall in maternal mortality ratio by about 0.9% per year. We've seen an increase in life expectancy by at least 5 years per decade. We have seen a reduction in HIV, malaria, and TB. Zambia just was able last year to reach its 90-90 target, and 90% of the people who are HIV positive knowing their status, and 90% of those people who know their status been on treatment, and 90% of those people on treatment are virally suppressed, which is impressive. This is towards achieving epidemic control of HIV. We have seen a fall in maternal mortality rates by about 50%. And in Zambia, we have seen a reduction in maternal mortality as well from the figures we had before of having maternal mortality, which was at about 378. And now we've come down to about 178. And we also have, unfortunately, we see a rise in NCDs, like I said. About 80% of cervical cancer occurs in the developing world. In my country, Zambia, cervical cancer is the most common cancer that we have. And this is a preventable cancer. So it's also that the health systems in Africa and health systems in most of the developing world are still skewed to managing communicable diseases. We've seen the impact of COVID. It's been about budget constraints. We've seen funds redirected from cancer control and other health services to fighting the COVID pandemic. We've seen supply chain challenges, which with export bans that were going on in the world. We saw that there have been shortages of drugs and commodities which are with cancer, particularly cancer drugs, which do take a long time to be able to manufacture. We've seen that in the movement restrictions of people, some people have ended up not going to get screened or to get preventive, to get vaccination. We saw a fall in vaccination in Zambia. We saw a fall. We had the first vaccination was about 82%. When we did the second dose, we found that we had reduced. The second dose was about 60%. So you see that there has been marked impact by COVID. And of course, with some of the diarrheal diseases in children and other vaccine preventable diseases not being prevented, and even maternal mortality itself, you start seeing increase in morbidity and mortality because of the disrupted health service, which is not resilient. And then we see that cancer treatment services, you have to reimagine. We had to reduce the numbers of people who are coming for treatment for us to be in line with preventing the health workers from getting COVID, even the patients who are coming in from getting the SARS-CoV infection. So what are we talking about leadership? Leadership in policy means we need to start from the national level. If you're dealing with it at national level or at a global level, you have to make sure you have a plan in your cancer control. And national cancer control is key. And the national cancer control plan that you have must be able to be resilient. It must be able to integrate, and it must be able to absorb the shock, and you must find new ways of innovating. So you have to make sure you're prioritizing health promotion for cancer prevention and control. You have to make sure that you are using the digital hedge, the using of technology, things like telemedicine, telepathology, electronic medical records. We're using reference systems which are electronic. We can know who's coming for screening. We can know who's going for treatment. These are helpful. And ensuring that in the long term, we need to make investments, and we need to have policies that are looking into improved cancer control, infrastructure, and decentralization processes. What can be done at the national level, provincial level, and what can be done at the district? Even as far as cancer treatment, there are things that can be done at much lower level. We must begin to prioritize routine health services. Cancer research with COVID, we see how we have done research in saying what should be done, what should not be done. And knowing how COVID has affected us in the part of the innovation must come from evidence-based policies. So as we see it as a policymaker, from the regional level, from the global level, these must come in. Implementation, you have to coordinate from the national level way up to the community level, the national technical working groups, to the neighborhood health committees, letting people know what's going on and ensuring that they're getting the information. You have to road delegate for various points of cancer care. Self-sampling reduces the chance of a woman coming in contact with you, but also that itself has disadvantages in that you are increasing the number of the times a woman has to come through. There should be HPV positive. Tissue preparation, not by the pathologist, but maybe by a scientist in the lab. We have to think of decentralization, like I said, bring in community-based organization, faith-based organization, clearly defined referral pathways so that people will know who does what and where and what point in our cancer control continuum of care. We have to use electronic systems, innovative way of operation. How do the nurses operate? How do we operate? And finally, we need to be able to clearly give guidelines on dissemination, information on COVID and its effect on cancer from the national level to the community level. We have to embrace virtual platforms, even in the developing world, where we thought, no, maybe we can't. So as a policymaker, ensuring that control towers are there is important. And every time dissemination of information and making sure the workers know the guidelines of how to reduce infection for themselves and for the people who are coming to see them. Finally, it's about refining your work all the time. Innovating all the time is very important. I sincerely thank you to you all for listening to me in this presentation that I have talked to you, and hope that we can discuss more as we go in the plenary.
Okay, great. Thank you to all of our speakers. I would like to encourage all of them to please turn their cameras on if they are able to right now. And we're going to start to dive into our questions. And this is, I guess, where I really make a living, because we had a lot of great questions. Fortunately, we have about 20 good minutes to get to them. So I'm going to jump right in, and I will do my best to direct these to our different panelists. The first one was one of the very early questions. I'm guessing that it was sparked by Dr. Atun or Dr. Peters, but I want to actually ask all of our panelists to briefly give a remark to what I think is a hard question, and it is, what would be your advice to LMICs, many of whom have very fragile health systems that were already overstretched before the COVID-19 pandemic? So just your sort of, if you had to have sort of one best buy or one, what would that be? And I'll go in order of our panelists. So Dr. Atun, could you make a quick comment for us?
Thank you, and that's a really great question and a very challenging one too. I think my experience suggests that coordination and better use of existing resources can really help create great value, much more so than what is created in fragmented systems. So an integrated approach to planning, an integrated approach to use of human resources, and as Dr. Campomway very clearly showed, focusing a coordinated way of implementing programs is really critical. And engaging, when I talk about resources, I'm not just talking about healthcare workers, community engagement. So using all the available assets to implement a program would really help create the positive synergies that we need to augment the care and improve quality. And of course, technology is also one of those enablers, because the additional cost of use of technology is actually very low. The marginal, so once this technology is in place, it can be scaled up at a very low marginal cost.
Wonderful. Dr. Peters, to you.
Thanks. Now, I actually answered also in the chat, so I'm not sure if I get an extra one but I totally agree with the concept of using the resources from within. One of those most neglected is actually, reaching out and engaging with communities, which really should be a starting point. And that's advice for any country. It's not actually related to a level of income. And in fact, many high income countries have done that pretty badly. But certainly, what we thought was talking about in terms of being able to organize and coordinate is critical across sectors, across government, bringing in all the kinds of social capital that you have, but also technological information, being able to have the detection and response systems. And the kind of things that Dr. Campomway was talking about are absolutely critical in terms of design and implementation of these kind of responses. So thanks.
Yeah, thank you, Dr. Peters. And to you, Dr. Carla Unger-Saldana.
Well, it's difficult to add anything after all that's been said. I would just focus even greater on this coordination aspect, saying that it's so difficult to make a health system work when it's fragile, like who is going to be in charge of this coordination. So maybe coming back to doing it locally and I don't know, by municipality, looking at what resources you have and knowing each other and being able to collaborate when there's no regulatory entity functioning like we would like. Maybe this could allow us to be more resilient. At the end, resilience comes to the individuals and what they decide to do in the moment and how they act with what they have.
Okay, great, thank you for that addition. Dr. Chiambere, what are your thoughts? If you could have sort of the one, what would you recommend? What would that be?
And can you repeat the question for me, please?
Absolutely, yeah. So it's a hard question, and it is, what would be your advice to low to middle income countries who already had very fragile health systems that were overstretched? So you obviously have a lot of lessons learned. What would be your one piece of advice about building a resilient health system when it's already fragile?
Thank you very much. The previous speakers have answered it very well. I just add the adaptability piece. So to be able to adapt your intervention and your resources according to the priorities, because there have been situations where the resources are not spent where they have to go. Really to work together to identify those areas which are suffering the most and which are the priorities to get the needed resources. Thank you.
Thank you. Yeah, that was a well-stated, I think, addition with regards to prioritization, which is very hard, I think, in the face of all of it. Dr. Campomway.
I think one of the things that I would talk to is avoiding silos. As we have seen COVID come in, all systems have gone, looking at the COVID-19 pandemic, and you find that we are slowly again beginning to build these silos towards this and forgetting the other issues that are going on. So even as new diseases will be coming in, to ensure that from avoiding silos, we're trying to make sure that they are integrating with other diseases. If you look at COVID, what we're using for testing, for example, in Zambia, we're using the GeneXpert machines. You've got, your Cobas machines, these PCR machines, which we can also use for like HPV testing. And what we have to make sure is that we don't go into the realm where we're saying, no, this is just for TB, this is for COVID, but to ensure that with the resources that we're having, as we are buying more machines for COVID, even when COVID is going down, to ensure that other diseases are also beginning to use these platforms. And even for cancer, we've seen that it's possible for us to be able to engage even on a global world with a telepathology, ensuring that we have all these digital microscopes everywhere, and you are able to get support, for example, an MOU that we are about to sign with the American Society of Clinical Pathologists, so that then it starts helping you improving even when you have these fragile system when it's happening, but we're able to get these results with a much better turnaround time.
Right. Thank you. We're going to continue with a lot of questions. This one I think is going to be geared towards Dr. Peters. The comment is great talks. The ID experiences like Ebola do offer models for cancer, but can the speakers talk a bit about the challenges in applying ID-based models to cancer and thoughts about how to address those challenges?
Thanks. Another easy question, right?
I told you, this is where we make a living.
Exactly. Well, I think, certainly there are some important differences between the type of epidemics that we're talking about, not only because they're dramatic, but the short incubation period. And so there's that short latency between an exposure and a bad outcome. And so you're more likely to grab people's attention to those things that have, long latencies, long incubation periods after exposure. So quite different. That means very different risk perceptions. So that's one of the big challenges, as well as that then makes it, I think, in many respects, it makes it harder to respond coherently, even though, in theory, you should have more time, but it's harder to prevent things in particular when the outcome is so much later. But I think what you do pull from it are the kind of things that are still relevant. One is you do need to have coherent, organized leadership that both has decentralized in that information and resources and autonomy go from bottom to top and backwards in terms of feedback, that you have integration in terms of communication, collaboration across government sectors. I think with cancer, there's I think a lot more that needs to be done, not only just with communities and to be able to listen to patients and families and civil society, but also with industry, because there's very different kinds of ways in which you would handle industry, from which you would do with a tobacco company to a pharmaceutical company to, say, the control of food systems that are, increasingly in large multinational corporations. That is also, very much related, not just to obesity, but to cancer. So you still need that kind of cross-sectoral coordination, not just across government, but across society, and building up the information systems and linkages that are needed. Again, from community to providers and from clinicians to public health, and then beyond to the other sectors. So those similar types of themes are needed. You just have a little more time and a little less recognition of the urgency.
Thanks. Yeah, I think one thing that I consistently heard echoed through everybody's talk is the health information systems and the data collection systems, the EMRs, and the sort of tech innovations. I'm obviously an epidemiologist by training, so anything that provides data, but I think everybody touched on it in its own way as sort of a foundational sort of capacity, is this element of health information technology. So that we have the data to do a lot of the coordinating that you guys are commenting on. This is an interesting question. I'm not sure who wants to tackle this first, but it says the adverse effects of the COVID pandemic on cancer are well noted and recognized. However, what have we learned as a consequence of unintentionally less intensive care about changes in current protocols that may warrant serious consideration? And the example would be sort of decrease in treatment intensity, fewer chemo or radiation cycles. I think it's an interesting point and can sort of consideration as we come out of this and reconceptualize what our healthcare systems look like, what our protocols look like. Dr. Chiambere, would you like to comment on this? I know you're really at the forefront of thinking about this as an oncologist and a clinician, and then open it up to anybody else.
Sorry, and I ask you to repeat the question again. I'm sorry for that.
Absolutely. The question is about what are your thoughts on really giving a consideration to some of the unintentional consequences that have come out of this from a treatment perspective, And the example here would be whether there is any merit in looking at less intensive treatment algorithms, which have happened unintentionally, but may have some merit to them.
And unfortunately, as far as I can remember, our treatment protocols here remain the same as before the pandemic. So we'll not be able to comment on that because we are still using the same protocol here because we use really less intensive protocol, if I can say.
Yeah.
So there was no room to make them less. Again.
Yeah, I think you know, it'll be a natural experiment. I hate to use that when we think about what, you know, our cancer patients' lives, but I do think there'll be opportunity for better or worse to look at that through our surveillance. Dr. Atun, I see you raised your hand. We'd love to hear from you.
Yes, absolutely. Thank you, Anne. And as I presented earlier, a number of countries indeed did change the regimens, but they also changed the process, which is also very important. And what has changed was the mix of interventions, sort of surgery versus chemotherapy versus radiotherapy. Also changing the medicines used and the periodicity of the treatment applied, but also how the care was delivered. And of course, we really need to know, again, many of these changes were intentional. Now, whether there are going to be unintentional consequences is yet to be shown, because we really need to measure and understand what the effects were, whether these had beneficial effects or whether these have adverse consequences, and what this meant in terms of patient well-being as well as cost. But I think what is very important as a lesson is whenever one is making such a change, one should put in place data systems to measure what has happened. So what happened before and what happened after intervention. So one can compare and contrast the positive or negative effects of the changes that were introduced. And often the changes were included multiple components. So in terms of design and analysis, they'll be quite complicated to demonstrate the effect of one change or multiple changes. But I'm sure many of the colleagues like yourselves working in epidemiology and other areas would love to address questions like that. But I'm working in a couple of countries to understand the effects of these. And often the data systems were not in place to really understand what the long-term effects might be. And that's a real shame.
Right, that's something we can work towards doing better next time, as Dr. Peter said, coming out better from all of this. Yes. I want to be mindful of time. I'm going to, just so our speakers know, I'm going to try to get through 2 more questions, and the rest that we have not gotten through, we have recorded them and we will follow up because there's some really great ones. The first one I'm going to go to is, no pun intended, $1 million question. This is from Patty Gravett. She said, excellent talks, very convincing evidence that we need both technical and social innovation to strengthen health systems for resilience to support cancer control programs. Do the speakers have an idea on how funders can better support the research on the social innovation side of this equation? Dr. Campomway, I think we will see if you have any initial remarks, and then we'll open it up to our panelists.
I think when we try to think of some social type of research that we should engage in, we first need to understand how people have actually, conceived COVID. We haven't really gone out. We know that there's a lot of misconceptions and everything, but because of the situation we're in, we have not really gone out to qualitative study, qualitative studies in as much as to find out from the people on the ground what this entails. And what we have seen, for example, in prevention programs like screening or vaccination, was an immediate drop when the first case was announced in the country. That means that, yes, people are fearful, where you can kind of extrapolate that there was a fear when they heard that, cases have actually been recorded in our country. is this fear still there because we're still having cases of COVID going on? And I think it would also be important to see how people receive, they get the vaccine. Can they now come and get treated, or they're still thinking they shouldn't be coming? What are the myths and misconceptions between the vaccine and cancer services in our communities? What information is going on? We really need to understand, because we've had a hit of people staying away even from treatment because they are thinking they're going to come and get COVID. And I already have cancer, and if I get COVID, it's going to make worse. Maybe I should stay away until they control the COVID. So there are a lot of questions that are going on in our communities that we have been unable to ask. And I think we can do that even innovatively, both to the patients and to women who are or men who are well, and especially women, if they are coming for services of screening, how they feel about coming into our facilities to be able to get that service. And I think this is a time also to research how much people are now more willing to go for things like self-sampling, which reduces their contact with our facilities, and that how that can enhance some of like where we have a common cancer like cervix in uptake of services.
Dr. Saldana, maybe you don't want to comment on the funding aspect of this, but I really see a lot of your research looking at delays, and this was largely done even before COVID, right, in completing that continuum of care. So can you talk to, if not the funding side, the importance of social innovation before COVID, be after, and through all of the other threats that we might endure across our countries?
You mean as a possible solution? I think it has a lot of potential. I also wanted to comment, like right now in low and middle income countries, it's being especially even harder to do research in the COVID era, since we don't have this information being collected administratively, you know? So for example, you speak about delays. I'm sure that delays are being worsened, but we don't know how much worsened they actually are, because we don't have the data. We might have it after COVID, no? I don't know. In Mexico, for instance, some hospitals have shifted to being only COVID. So it's not only the patients being afraid of going to the hospital because they don't want to get COVID, it's also that they can't use the services as they used to. So there's challenges all around. And I saw in the chat, Ophira was asking for women, how is this having an impact? I think it's even harder because they have the kids at home because no schools are working, and they're supposed to be there at the hospitals as nurses, as doctors, as researchers. It's having a very hard impact on women. There was this cartoon that I saw where you see the woman sitting on the computer with cooking at the same time, washing at the same time, the kid underneath pulling her, no? And the man is in his room saying, oh, this is great. Now I get to work in my own studio. I can close the door and, no? So yes, for women being particularly challenged, and for healthcare personnel, we need to take this into account when speaking about resilience. What can the system do for female health workers, which are the majority nowadays?
And I am just going to quickly read that question so that we can have one final comment, since Ophira's question is well placed, and everything you said, Dr. Saldana, resonates probably with, you know, I think every woman, and certainly in egalitarian families, right, with the men as well, who are watching this happen to their mothers and sisters, and I don't want to discount that. So just briefly to Ophira's question, and thank you for your comments, and to open it up to maybe one more. First of all, highlighting all of the strong women on this panel who are part of the Lancet Commission on Women and Cancer. And the question then that I'll pose very briefly is what are the panelists' thoughts about the particular impact of COVID on women as healthcare workers, formally and informally, and on women seeking care? And I know Dr. Campomway has, and so has Dr. Saldana, commented on the issues of seeking care. Any final comments on the long-term impacts on the female workforce? As we know, right, they're sort of the future of the workforce in so many countries, And we already had a lot of issues with human capacity and retention. Any final comments?
I think one of the things we've seen is in terms of prevention, even treatment, is that we've seen that prevention has suffered in that, and mostly the women who are doing screening, who are doing CBs for breast, women. And when we've had other like treatment or delivery, deliveries, the labor ward and everything being short-staffed, the first place that is getting shut down are the preventive services. So the female health workers are being transferred to go and work. They are being assigned to go and work in these high volume clinics to go and help in the deliveries if they're midwives and everything. So you see that in the end, we see as a reduction, because not that the women are not coming in some instances, but the health workers have been moved to the treatment or to the delivery rooms, and our services, routine services, then get a hit by seeing a reduction. So women will go back with the problems they came with, and if it's a cancer, then we lose out. If the woman is coming from far, if she's going to come back, so it's a cost. And for women, I think the impact, Carla has talked to it. It's massive. It's yeah. They come to our facilities. If they don't find a service, then they don't come back. It's a cost. Already their businesses as in the informal sector has been hit. Even if they're just selling by the roadside, it's hit. And if they have to come miles to come and get treatment or to come and get screened, and they don't find the clinics open, that has implications. They'll stay away more, but they can be going around with the disease, which can take them later.
I know we don't have time to do justice to that question. That's the downside to our trying to get to so many great speakers. And I hope just by posing it, we can start to think solutions to that, and obviously an important area for building resilience. I'm going to do a very quick ending since I want to keep us on time. I don't want to be the one that has shifted our entire day, but to sort of give a very big thank you to our speakers. I was really excited when you all decided to be on board with this and help us really think through what I think will be critical moving forward. And a few just logistical notes. The questions that we did not get to, we will try to get to offline via text, via email as best as we can. Also, a note that slides will be up during the break with a link to the poster site and other key announcements. We're going to take a 3.5-minute break before we come back to the oral abstract rapid fire session, which will begin promptly at 9:45 Eastern time. So that's about 3.5 minutes to have a drink of water. To end quickly, thank you so much, and we look forward to the follow-up conversations.
Okay, welcome back. Hello, my name is Carl Allen. I'm a pediatric hematologist oncologist at Texas Children's Hospital here in Houston, Texas. So greetings from Houston. I know that your break of 3.5 minutes was probably insufficient, but I want to keep us on time so we have the ability to get the most out of this session. Personally, I think that oral abstracts are the most rewarding or my favorite part of most meetings, because we have the chance to interact with a lot of different people and engage in dynamic discussions. We'll do our best to recreate that experience virtually here. I wanted to share with you that we have 10 fantastic abstracts that will be presented. We had over 100 abstracts submitted representing a broad array of topics. They went through a rigorous review process and were scored according to quality, as well as to cover priority topic areas to make sure we have lively discussions at the symposium. So you'll be able to review the abstracts that you see presented here in more detail at the link that's going to be displayed on this rotating slide deck here, as well as the other 90+ abstracts. And we really encourage you to reach out to the presenters for follow-up discussion. So we look forward to discussion on areas including cancer control and prevention, early detection, diagnosis, and prognosis, as well as treatment. Again, this is going to be a high-level, rapid-fire presentations. We've tried to cluster these into similar areas of content. So after we have our presentations, for each area of content, we'll then have discussion. So please put your questions into the chat, and we'll try to make sure we make this as interactive as possible. So thank you once again to everyone who submitted their inspiring and excellent work to the symposium. We look forward to these discussions. Thank you very much.
Thank you, Dr. Allen. My name is Lindsay Aldridge, and I am a fellow at the U.S. National Cancer Institute Center for Global Health. And I want to thank everyone in attendance today, and especially thank you to our 10 presenters that are here to share their great work. So I'm really excited to begin our session with 2 presentations on the topic of cancer control and prevention. So first, you'll hear from Ms. Rifa Akanda, followed by Dr. Victoria Sanchez-Antelo. And as a reminder, a 3-minute Q&A will follow each topic area. So please submit your questions using the Q&A box at the bottom of the screen.
Hi everyone, my name is Rifa Akanda and I'm a graduate student researcher with the UCLA Fielding School of Public Health. My colleague and I are very excited to present our research on the cervical cancer policy landscape in Sub-Saharan Africa. So the purpose of this study was to understand what policy measures are in place in Sub-Saharan Africa to mitigate the burden of cervical cancer. We know that the burden of cervical cancer in Sub-Saharan Africa is high and that policy can impact financing, service organization, discourse, and behavior of prevention efforts. So we wanted to understand whether the high burden of cervical cancer was yielding a proportionate policy response. Policy responses to cervical cancer prevention can be categorized as primary, secondary, and tertiary, with preventative services respective to each level of prevention. However, it became imperative that we were not only analyzing the presence of these policies, but also the content of these policies to understand how they might influence population health outcomes. Thus, our objectives for this research study was to, 1, identify the presence of cervical cancer policies in Sub-Saharan Africa, and 2, to analyze the content of cervical cancer policies for comprehensiveness. So we utilized a web-based search to locate and record policies available for each Sub-Saharan African country. We then analyzed each policy document for primary, secondary, and tertiary prevention components and created a summed scores. Scores were based on whether a prevention method was included in the policy and being implemented. Primary prevention components could receive a score between 0 to 4, secondary prevention components could receive a score between 0 to 6, and tertiary prevention components could receive a score between 0 to 2. We then compared each country's sum scores with factors that we hypothesized to be associated with the policy environment. Factors that we hypothesized to be associated included each country's health financing trends, economic status, female health outcomes, sub-region, and policy environment. Our results supported that there was a variation in both the presence and comprehensiveness of policies themselves, and that the comprehensiveness of policies also varied by external factors. We found that there was a substantial variation in the presence and the comprehensiveness across policies. Primary and secondary components were not only more commonly included than tertiary prevention, but they're also generally more comprehensive. Most common components included in policy documents were target age, vaccine schedule, and screening methods, but these details varied substantially across countries. With respect to the hypothesized associated variables, we found that for geographic location, policies were more comprehensive in Eastern and Southern Africa. Additionally, the financing and policy environment were associated with the comprehensiveness of cervical cancer policies. Countries that had higher external financing for health and higher HIV prevalence had slightly more comprehensive cervical cancer policies than those with less external health financing and lower HIV prevalence, respectively. This analysis identified that there is a variation in the presence and comprehensiveness of cervical cancer policies in Sub-Saharan Africa. We hypothesized that there is a variation in the comprehensiveness of policy with a focus on primary and secondary prevention due to health system constraints that limit access to tertiary and palliative care, which constitute tertiary prevention methods. Additionally, there is a substantial amount of donor funding in the fight against HIV, some of which has been leveraged for cervical cancer prevention activities. This high donor funding against HIV may be why policies in countries with high HIV prevalence and those with high external financing for health had more comprehensive cervical cancer policies. This may explain why countries in Eastern and Southern Africa had more comprehensive cervical cancer policies, as countries in these regions, such as Kenya, Malawi, and South Africa, have a high HIV prevalence, again, potentially reflecting this donor attentiveness. Our study highlights that cervical cancer policies in Sub-Saharan Africa are heterogeneous, and that there is room for improvement. We recommend that these countries focus on strengthening their policies and capacity for delivering tertiary prevention. This may help decrease the burden of cervical cancer in Sub-Saharan Africa, especially for women who present with late stages of cervical cancer where their only option is treatment. We also recommend that countries consider how their policies can follow comprehensive cancer control guidelines that encompass the continuum of primary, secondary, and tertiary prevention. Finally, we also recommend following global recommendations to increase the efficacy of cervical cancer prevention. Thank you all very much for listening to our presentation, and we are looking forward to hearing your questions.
Thanks for attending our presentation. I'm Victoria Sanchez-Antelo from Argentina. On behalf of the team led by Dr. Rossi, I'm going to present the preliminary results from our formative research that aims to design a counseling app. As you know, HPV testing detects sexually transmitted infection with oncogenic types of HPV. From women's point of view, an HPV positive result may have negative connotations and can cause emotional impact. The psychosocial impact of HPV testing can generate negative thoughts among women, and they can consider unnecessary to continue follow-up. This psychosocial impact can be faced with counseling, but face-to-face counseling found many obstacles for its implementation, and we suggest that mHealth intervention can be an innovative way to overcome implementation obstacles, and a counseling mobile app may help HPV positive women to reduce the psychosocial impact of results, improving their knowledge about HPV and cervical cancer, and as a consequence, increase their adherence to follow up. But what is special about this project? Well, our theoretical background is based on a user-centered design, that is an approach where end users participate as co-designers. We also use the Help-Believe model and the integrated behavioral model to specify app contents. The research involved lower middle income settings from Buenos Aires. We carry out intentional sampling procedure among HPV positive women aged 30 and over. For data collection, we carry out 29 online individual interviews and 4 virtual focus groups. Today, I'm going to present the focus group results. These describe women's experiences and emotions related to HPV testing and their results delivery, and their expectations regarding the app to reduce emotional impact of HPV positive results. This data will allow us to obtain the information architecture of the app, that is, how to organize contents into tools and how contents should be organized in a set of labels and app screens. We use thematic analysis and R software for data processing. As the quote shows, we found that women needed information regarding the procedures they have received, what HPV means, what are the causes of HPV, if the HPV is present only in females, and if HPV has consequences on their sexuality. We also found that women's fears of disease and death could increase after medical consultations. On occasions, they were left with unanswered questions or misconceptions, such as believing that HPV positive is a synonym for cancer. To get information, focus group participants accepted the app as a tool, and they thought it could be useful to reduce fears related to HPV positive results. They could use an app if the doctor or health authority recommended it. They believe that apps should provide information through video, illustration, or infographics, but not by pictures or text only. The app has to offer information on next steps in the follow-up and medical appointment reminders. Finally, providing counseling and information that meets women's needs could be a way of reducing fears linked to HPV and cervical cancer. A mobile app seems to be acceptable and suitable tool to provide support to HPV positive women. Thank you very much.
All right, thank you very much. Those were really fantastic talks from opposite parts of the globe, I think on some common problems. And maybe I'll start with a question for Ms. Akanda. You have this unique opportunity to look at a sort of a group of countries to kind of examine the range of policies. And I was just wondering if you had an opportunity to kind of compare the region in general of Sub-Saharan Africa to other regions with respect to content and heterogeneity of various policies.
That's a really good question. So we actually only focused on looking at Sub-Saharan Africa just because we were aware of this high burden in this specific region. However, I think that it would be interesting to kind of try and see maybe how these policies and the heterogeneity of these policies would to compare to maybe other countries, maybe even the United States, where the burden of cervical cancer isn't as high and where there are differences and similarities in the policies.
And in your region of study, were you able to identify an association between the level of policy and clinical outcomes or incidence of cervical cancer?
So we did look at rates of cervical cancer and then seeing whether or not there was any correlation or association with the scores of the policies respective to each country. And we didn't find any significant statistical findings between the two, unfortunately, which was a little bit surprising. But it also could just be because maybe the policies are not actually reflective of the clinical outcomes of cervical cancer.
Okay.
Now, it looks like we have a question from the audience for Dr. Sanchez-Antelo. Someone asked, what is the social acceptance and availability of HPV screening and HPV vaccines for young men in addition to young women? And they also added as a follow-up, if you could comment on the availability acceptance of HPV screening for young men.
Okay, thank you very much. I am a sociologist and I don't have information about vaccination on men or women now. But in the previous years, the National Health Cancer Institute promote vaccination in childs, but I don't have number for this for answer this. Sorry.
So, and Dr. Sanchez-Antelo, your app looks really like a really innovative tool, and I was just wondering if you could comment on plans for implementation or possibly even expansion to other diseases.
Yes, we are focused on cervical cancer, but from focus group results, we saw that women's demand a more integrative tool to promote different cancer prevention issues for women and also for men. And we are exploring how to add new tools for this pilot project. We are going to test in 2 design sessions in the next month with women and to test usability and to test the comprehension of the contents that we are designing.
All right, thank you very much. Lindsay, do we have time for one more question?
So unfortunately, I don't think we have time, given just the nature of these rapid fire sessions. So I want to thank Ms. Akonda and Dr. Sanchez-Antelo again for your great work and for being here today to answer questions. So we're now going to move on to our second topic area, and our next 2 presentations will focus on early detection, diagnosis, and prognosis. So first, we'll hear from Dr. Chemtai Mungo, who will be followed by Ms. Elizabeth Masoka Bright.
Thank you for having me. I will be talking about results on our study looking at whether we should use visual inspection of acetic acid to triage HPV positive, HIV positive women who are undergoing cervical cancer screening in a low resource setting. I have no disclosures. So we know that HPV testing has superior sensitivity for diagnosing high-grade dysplasia, the lesions that are most likely to progress to cervical cancer. And HPV testing is recommended as a first line where available for cervical cancer screening in low resource settings. Several guidelines recommend using visual inspection with acetic acid, VIA, as a triage test, but VIA has certain limitations. In this analysis, we determined the positive predictive value of VIA for diagnosing CIN2+, that's diagnosed by gold standard amongst HIV positive women who are also HPV positive in a low resource setting. This study was part of a clinical trial that took part in a PEPFAR-funded HIV clinic in Western Kenya. As part of a larger trial, HIV positive women who are between ages 25 and 65 years who are HPV positive as tested by CARE HPV were enrolled. All women had visual inspection with acetic acid, colposcopically directed biopsies, either of a known lesion or a random biopsy, and same-day treatment of all women, regardless of VIA result. And in this analysis, we determined the positive predictive value of VIA for CIN2 based on histopathology. The study enrolled 369 women. Mean age was 40.2 years. The median CD4 count was 420, and 94.5% of these women had HIV viral suppression. We see that out of the 369 women, 20% were found to have CIN2 or worse on histopathology, while the rest had CIN1 or normal results. Amongst the 74 women who had CIN2+, upon VIA by a trained provider with years of experience, only 33 were also VIA positive. This gives a positive predictive value of VIA of only 44.6% for diagnosing CIN2+ amongst HPV positive, HIV positive women. The 95% confidence interval was between 33 and 56.6. When looking at the subset of women with only CIN3, the positive predictive value of VIA did not change much. In looking at the trend of the positive predictive value based on age group, we find that women ages 30 to 39 had the highest positive predictive value of 72.7, while women greater than 50 had the lowest positive predictive value. In conclusion, amongst HIV positive women who are also HPV positive, we find that VIA has a low positive predictive value for diagnosing CIN2+, as determined by histopathology, which is a gold standard. This would result in missed opportunities for treating CIN2 in this high-risk population if VIA was used for triage. In this case, less than 50% of the lesions would have been treated. This highlights a need for more objective yet resource-appropriate triage tests to use within screen and treat programs in low and middle income countries. Thank you.
Hi, everyone. Thank you for the opportunity to present today on healthcare providers and traditional healers' perspective on late diagnosis of breast cancer in Tanzania, a qualitative study. 80% of women with breast cancer in Tanzania are diagnosed at advanced stage. The reason for it are multifactorial and have not been investigated at Kilimanjaro region. So this study aimed to identify reasons for advanced stage of disease at time of diagnosis from the perspective of community, patients, healthcare providers, and traditional healers. The focus for this presentation will be on healthcare providers and traditional healers. The study were conducted both from rural and urban setting of Mosh Kilimanjaro regions. This abstract is presenting subset of data from the large study. That's highlighted here are results of in-depth interviews of 10 doctors, 10 nurses, and 8 traditional healers that were coded and analyzed via grounded theory approach. From the perspective of healthcare providers, common themes for the reasons for advanced breast cancer at time of diagnosis were patient initially seeking care from traditional healers and patient distrust conventional medicine. And this was demonstrated by a 36-year-old male doctor from Moshi Rural District Hospital who says, there is an old traditional woman who is well known by majority of our patients here in Uchira. Some of our patients tell us that the truth, that they started to take her local herbs with no effects, and now they have started our treatment, but it's late. Similarly, the emerging themes from the perspective of traditional healers were delayed initiation due to long turnaround of pathology results, inability to pay for diagnostic workout and treatment, and lack of transportation, as it was demonstrated by 81-year-old male traditional healers from rural Mwanga district, who says, when my wife had a breast lump, it took me more than a month waiting for results, and she died of breast cancer. Furthermore, lack of breast cancer knowledge among patients were found to be mentioned by both groups of our participants, the healthcare providers and traditional healers. And this was demonstrated by 58-year female traditional healers from Moshi Rural. She said, client will tell you that I don't know what has caused this wound. It starts as a small pimple, itching, but I tell them to go to the hospital. But also, a 47-year-old female nurse from the Zonal Consultant Hospital in Mosh Urban said, most of our patients doesn't have enough knowledge on signs and symptoms of breast cancer. That's why they come with advanced stage of the disease. In conclusion, we found that there was an agreement that lack of adequate breast cancer knowledge and awareness is very common reasons for advanced disease presentation among healthcare providers and traditional healers. So community health education must be designed to adapt sociocultural rules in order to alleviate misconceptions and knowledge gap, as well as healthcare system interventions are needed to facilitate access to timely, affordable, and quality breast cancer diagnosis and treatment. Thank you everyone who contributed to this study as is listed in this slide. Asanteni.
Great. Thank you again for two really excellent presentations on very relevant, important topic areas. So again, I want to remind everyone to please submit their questions through the Q&A box at the bottom of your screen. So while we wait on questions from the audience, I again want to turn it over to Dr. Allen and see if you had any questions or comments for our speakers.
Sure. Thank you. Those were excellent, excellent presentations. Maybe I'll start with Dr. Mungo. And I mean, I think it's really important that we test practice and see if it's doing what we think it's doing. And so based on your results, I guess I'd ask, do you think there's any group for whom visual inspection is appropriate, or do you think this should be, at least in the setting that you tested, should this be abandoned?
I think in the setting with access to HPV testing, I would be very reticent to triage with VIA because you're losing, a lot of the gain of being able to diagnose or treat, high-grade disease. I think that, we should treat all HPV positive women but continue the research to find better tests, including using biomarkers, using AI-supported cervicography. Certainly, the VIA did better amongst younger women, but even in the 40 to 49 age group, which is the kind of high risk group for CIN2, it didn't do so well. And in settings where women only get screening once every 5 or 7 years, if we're lucky, I don't think that the risk of losing out on half of women who would get treated is worth it.
So, and do you find that women who get screening have less comprehensive evaluations than women who don't get screening?
What do you mean by less comprehensive evaluation?
I guess, do people act on the screening as sort of, if the test is negative, that the evaluation stops there, or is it used to complement?
Yeah, I think that people, once somebody's given a negative result, there's a lot of reassurance. So it could be very easy for a woman not to come back for 5 or 7 years, especially with speculum-based screening, because women just are reticent to have that. So it would be, giving false assurance to some of these women who just would, are not getting screened often enough.
Thank you, Dr. Mungo. So we now have a question for Ms. Masoka Bright. How can we change the mindset about delay in seeking care through mass media, use of local health workers, et cetera?
Thank you very much for the good question. Can you please repeat the question again?
Yes, so our question, they asked, how can we change this mindset about delays in seeking care?
Okay, thank you very much.
Sort of how do we improve care?
Okay, yeah. So I think it will be very important for us healthcare providers to keep on raising awareness to our community, but also to raise awareness among ourselves, because with that, our community will get to be aware of the conditions, as well as they will be able to know where to seek the treatment. But also, I guess there's also important for the government, especially the government that we have now. It's a very polite and active government, that we are sure that by raising more and train more healthcare providers, they will distribute them as far as to the rural regions, whereby they will raise more awareness to our people, and they will really seek the care from the healthcare setting. Yeah.
Thank you. And just given time, I do want to move on. We do have a lot more questions for our speakers. I just want to remind our audience that you can view the posters for each of these speaker presentations on the poster tab of our events page. You will also be able to find our presenters' email addresses there, and I'm sure they'd be happy to take your questions offline. So I now want to move on to our third topic area. And we'll be hearing from we'll hear two presentations on treatment of Wilms tumor in children in Tanzania. So our two presenters are Dr. Austin Wesovich and Dr. Mocha George.
Thank you for joining today for a virtual conference. My name is Austin Wesovich, and I am completing my residency at Duke University in combined internal medicine and pediatrics, and will move soon to the University of Chicago for adult hematology oncology fellowship. Our team from Bugando Medical Center in northern Tanzania and from Duke in North Carolina are eager to share with you our findings when looking at Wilms tumor treatment protocol compliance and the influence on survival outcomes for children treated at our hospital. Wilms tumor treatment outcomes are worse in low and middle income countries, or LMICs, than in high income countries. Thus, we sought to identify critical breakpoints in treatment protocol adherence and clinical practice. We did so through a retrospective single-center cohort study. We reviewed the charts of 72 children diagnosed between 2016 and 2019 with Wilms tumor at Bugando Medical Center. They were treated either through the International Society of Pediatric Oncology, or SIOP, Adapted Africa Protocol, or Standard Protocol. We looked at where patients abandoned care in the treatment cascade, where we define abandonment as missing 4 or more consecutive weeks of scheduled treatment. We also looked at what stages patients passed away and the compliance to the protocol at each stage. Finally, we assessed 2-year overall survival and event-free survival, where events included treatment abandonment, disease progression, or death. This figure outlines the main findings of our study. While 85 patients were initially identified as having Wilms tumor, 6 of these were misdiagnosed and 7 had incomplete files. Thus, our sample focused on the remaining 72 patients, of which 3 died before preoperative chemotherapy, 63 initiated preoperative chemotherapy, and 6 skipped preoperative chemotherapy for a variety of reasons, going directly to surgical resection. Prior to surgical resection, 12 abandoned and 4 died, and 45 completed surgical resection. Afterwards, 8 abandoned, 4 died, and 3 did not initiate post-op chemotherapy per protocol. A total of 31 patients initiated postoperative chemotherapy, as 1 who abandoned later returned. 7 abandoned during postoperative chemotherapy and 3 died, with a completion rate of 21 patients. This means that ultimately only 22% of patients completed recommended chemotherapy per protocol. A total of 38% of patients abandoned care, with 44% of abandonment occurring prior to surgery, 30% immediately after surgery, and 26% during postoperative chemotherapy. This level of protocol adherence led to the following survival outcomes. 2-year overall survival was 44%, and 2-year event-free survival was 27%. Compliance with postoperative chemotherapy was predictive of 2-year overall survival when looking at multivariable regression models. Our findings suggest that non-compliance with recommended Wilms tumor treatment guidelines due to key health system delays, as well as abandonment, correlated to reduced overall survival rates, particularly when looking at adherence to postoperative chemotherapy. These areas of health system delays can be targeted in future studies to improve treatment outcomes. I would like to acknowledge each member of our international team for their contributions to this study, and especially to thank Dr. Kristen Schrader for her mentorship. Thank you for your time.
Hi everyone, my name is Dr. Mocha George, a urologist at Rabinisia Memorial Hospital in Dar es Salaam, in Tanzania. Today I want to discuss with you a study which we did entitled Use of WhatsApp to Improve Medical Provider Communication for Children with Wilms tumor at Bugando Medical Center in Northwest Tanzania. So despite the fact that Wilms tumor is the most common renal malignancy in under 5 globally, but there is wide disparity in outcomes between these high-income countries versus low and middle-income countries, whereby the overall survival in high-income countries approaches 100%, while it is very low in low middle income countries in the range of 50% in Tanzania, sometimes even low, as presented by the previous presenter. In our setting, it was 44%. And the reasons are many, not only limited to this: abandonment of therapy, inadequate follow-up, poor treatment compliance, and late presentation. Most of the time, these patients were not compliant to treatment simply because there was poor resource availability, poor intra-team communication. There's also a low knowledge about the protocols. But again, with the wide availability and development of technologies, including internet, availability of smartphones, and coverage of internet even in the low middle income countries, then there is a room for mobile health technologies to offer a cheap and a priceless solution to the communication problem. So in our setting, normally if you receive a patient and you suspect to have a Wilms tumor and you want to involve either urology or pediatric oncology department, you have to draft a referral letter, you give it to the patient, and the patient will go to the respective department where he or she will be scheduled for the next outpatient visit. So in 2016, we initiated a Wilms tumor WhatsApp group, which covered the team responsible for the caring of our patients with Wilms tumor, including the urology team, pediatric oncology, and psychosocial support providers. On your right, you can see a screenshot of our group. So the aim of our study was to evaluate the use of WhatsApp to improve now the medical provider communication and treatment compliance for patients with Wilms tumor in Tanzania. So we collected a total of 669 messages for 55 patients, and the messages were coded for thematic content. The patients were divided into two groups, that is the group which were discussed and the group which was not discussed. And among the messages which were exchanged between the group, 44% were from pediatric oncologists, followed closely by the urology resident. Now, if we compare between the two groups, that is the discussed group and the not discussed group, the time to surgery, there was a reduction in the delay, that is 60 days in the discussed group compared to 90 days in the group which was not discussed. Same applied to the reduction in the time to initiation of postoperative chemotherapy, 19 days versus 46 in favor of the group which was discussed. Same applied to treatment abandonment, in which the group which was discussed, the abandonment was a little bit low, that is 26.7 compared to 38.2. So as far as our knowledge is concerned, this is the first study which was done to assess the use of WhatsApp in low and middle income countries in the management of children with malignancies. And as I said earlier, there is vast development in technology, including internet, including availability of a smartphone. And as we know that most of people, they are using the technology, including the smartphone and applications in their daily routine. Then there's a room for application like WhatsApp to be used and incorporated in the care of patients with malignancies, especially so in the low and middle income countries, in improving their outcome. Thank you very much, and welcome to Serengeti to enjoy the hippo pool.
All right, thank you so much. I think both these presentations sort of on a complementary topic were really quite informative. And maybe we'll start with Dr. Wesovic. To sort of ask you, your analysis of the of abandonment is, I think, a really important concept as we think about applying protocols. Were you able to identify reasons for abandonment? And I guess, would you say it's abandonment, or were there sort of systematic issues where the plan couldn't be delivered?
The data that we have in our databases was mostly just looking at kind of how many days had elapsed and different things, and we reviewed the charts when available. So we define abandonment as any greater than 4 weeks kind of without therapy, whether that was due to transportation or financial or miscommunication. If there was a time where the treatment that was indicated per protocol just wasn't identified by the team, then we did not count that as abandonment. We sort of looked at more patient-driven reasons, if that makes sense.
Very good. And I think along those lines for Dr. George, do you think that the results that you saw were based on the aspects of the app, or do you think that the concept of finding some strategy to coordinate multidisciplinary teams maybe underscored the improvement in results?
Sorry, can you repeat it?
So I guess I'm just kind of getting at, why do you think the WhatsApp use of WhatsApp improved outcomes? Was there some, which features of the use of this device by the team do you think led to the improvement in outcomes?
Okay, so what I think is the app actually, yes, create a shortcut. If you compare our standard of managing this patient, that is, if the patient is seen in the urology clinic, then you have to and you want this patient to be seen by the oncology for the pre-op chemo, then that patient might lose a day or two, because he or she have to go to the clinic, and then he'll be scheduled for the next visit. So if that patient is discussed in the group, the chances that this patient won't be lost to follow-up, because most of the patients, as you have seen, their treatment abandonment is high, because some of them, they were lost to follow-up because maybe they couldn't access funds for to come back to the hospital. But then there was a system to assist them in terms of funds. Therefore, the app actually brought the group together. That is the urology, the pediatric, and the supporting staff, creating a shortcut. I don't know if I made any sense.
Yeah, that makes perfect sense. And then are other teams sort of, are there other WhatsApp listservs being created based on the experience with Wilms tumor?
Sorry?
So, are other disease-based teams being created based on the success that you've shown with the Wilms tumor experience? Like, for example, with brain tumor?
So far, I'm not sure if it has been created, because we are currently circulating the results. Therefore, maybe from the result, then they will create the same thing.
I think these are both fascinating. I'd love to chat more about both of the studies, but I think we need to keep moving and keep the questions coming, and our researchers can answer your questions virtually. Thank you.
Great, thank you both. And yeah, again, just because of time, we'll have to move on, but maybe our speakers can respond directly in the Q&A. So we're now going to move on to our fourth topic area, and this is part 2 to our cancer control and prevention topic. First, we'll hear from Ms. Emma Brofsky, followed by Ms. Lydia Busenji.
Hello, my name is Emma Brofsky, and I am a scientific program analyst in the Division of Cancer Prevention at the U.S. National Cancer Institute. Today, I will be discussing the development of international cancer research partnerships through the NCI U.S. Latin American Caribbean HIV/HPV Cancer Prevention Clinical Trials Network, or as we like to call it, ULACnet. People living with HIV have elevated risks of HPV-related cervical, anogenital, and oropharyngeal cancers. Despite the availability and continued advances in prevention interventions for these cancers, their evaluation and implementation among people living with HIV has been limited. The National Cancer Institute has developed ULACnet, a new U54 cooperative agreement-funded international collaborative research network to expand this evidence and build on strong academic research partnerships developed for HIV research between institutions in the US and their counterparts in the Latin American and the Caribbean region. ULACnet was designed to expand the evidence in 3 research focus areas: optimizing dosing and delivery and evaluating new indications for HPV prophylactic vaccines, evaluating new biomarkers and technologies for cervical and anogenital cancer screening and triage, and evaluating non-excisional treatments for persistent HPV infection and HPV-related precancerous lesions. ULAC-NET is comprised of 3 partnership centers, each led by a US-based institution working collaboratively with US and Latin American and Caribbean partners to develop and conduct multi-center prevention clinical trials focused on filling key scientific gaps and evaluating novel interventions, as described earlier. As you can see in the center of the organizational chart here, the 3 partnership centers work with the NCI management team in the Division of Cancer Prevention. The coordinating committee in green is made up of the principal investigators from each site and meets quarterly to harmonize the research and discuss network-wide collaborations. The Clinical Trials Oversight Committee includes NCI scientific experts who review the protocols and provide recommendations for conduct and coordination of the clinical trials. On the left side of the diagram, we have 3 current working groups listed that focus on HPV testing and screening, pre-cancer treatment, and recruitment and retention. Additionally, we work with the NCI Office of Grants Administration, the DCP Protocol Information Office, and a regulatory and auditing contractor, as listed on the right in blue. It is through this structure that we have managed to create a fully functioning, productive international cancer research partnership. At this point, the partnership centers have been well established and are well poised to implement their first clinical trials in the next few months. To give you a little sneak peek, I've included the titles of ULAC-NET 101, 201, and 301. ULAC-NET 101 will be looking at optimizing screening algorithms for cervical and anal precancers in men and women living with HIV in Mexico and Puerto Rico. The second trial, ULAC-NET 201, is a placebo-controlled phase 3 trial that aims to prevent persistent oral HPV infection in men living with HIV using the already licensed Gardasil vaccine. This trial will take place in Brazil, Mexico, and Puerto Rico. The third study that is starting up, ULAC-NET 301, aims to identify the optimal dose of Gardasil vaccine for children and adolescents living with HIV in Peru and Brazil. There are at least 6 other trials planned for the network, and the scientific focus and population are listed in the bottom 2 rows of this chart. In conclusion, ULAC-NET will leverage and strengthen established academic global health partnerships to conduct high-quality collaborative clinical trials. ULAC-NET clinical trials are expected to inform clinical care recommendations and public health practice with a goal to reduce the burden of preventable HPV-related cancers in people living with HIV. On the left is a photo from the ULAC-NET kickoff meeting, and on the right, there's a photo of our recent virtual annual meeting. I would like to acknowledge my co-authors on this presentation from the Division of Cancer Prevention, the Office of HIV/AIDS Malignancy, and the Center for Global Health. Thank you very much.
Hello, everyone. Greetings from Rwanda. My name is Lydia Usinje, the Cancer Registry Officer at Rwanda Biomedical Center, Kigali, Rwanda. On behalf of the team that is listed on this first slide, I'm so glad to present on cancer update in Rwanda at this 9th annual Symposium on Global Cancer Research. Cancer is a health public concern in Rwanda. Cancer prevalence and death have not been accurately documented up to 2018 in Rwanda. To address this issue, Rwanda has launched the National Cancer Registry by the Ministry of Health through Rwanda Biomedical Center and by funding support from their partners. This was a tool to identify the most occurring cancer in Rwanda, to identify the distribution of cancer cases by type in Rwandan population, and to identify cancer trends over the last 10 years. We used a retrospective data from Rwanda Cancer Registry from over a period of 10 years, from January 29 to 20 December 2018. Data were abstracted from government and private hospitals, Center of Cancer Diagnosis, and National Institute of Statistics of Rwanda. All cancers have been abstracted from patient files and electronic medical records. The abstracted cases were coded and classified according to the 3rd edition of the International Classification of Diseases for Oncology. Then those data were entered into the CUGH 5 software and analyzed. According to the findings, over a period of 10 years, a total number of 18,562 cases were registered, and 11,034 cases were in men, while 7,528 were in men. Of the reported cases, breast and cervical cancers were most common cancers among women, while prostate and stomach were the most cancers in men. The pie chart here shows the top 5 cancers among Rwandan population. By the age group, the most cases diagnosed were in women aged 50 to 54 and 45 to 49 age groups, while in men, the most cases were diagnosed among men aged 60 to 64 and 55 to 59 age groups. In 10 years, the analysis indicated that cancers diagnosed in Rwanda increased from 759 cases in 2009 to 2,862 cases in 2018. In conclusion, this is the first analysis of cancer cases from Rwanda Cancer Information System since it resumed in July 2018. In Rwanda, cancers are more common in women and are diagnosed at an earlier age in women than in men. There has been significant increase in documented cancers over 10 years, potential related to significant improvement in diagnostic capacity within the Rwandan health system. Thank you so much. Thank you so much, Rwandan Ministry of Health, through Rwanda Biomedical Center. Thank you, the team that provided this abstract. Thank you so much for the Symposium team, organizing team that provided us space for presentation. Finally, thank you so much for your kind attention.
All right, thank you so much for those talks. Was there something in the chat or?
So we don't have anything yet. So to our audience, please feel free to send in questions.
Maybe I'll ask Ms. Brovsky, the consortium you described is really incredible. It looks like a really tremendous collaborative effort. I was wondering if you could just share with us, as these clinical trials are just beginning, as you look towards the completion of the trials, how do you envision sort of the results being integrated into sustainable plans for the regions where they're taking place?
Mm-hmm. Yeah, thank you very much for that question. Something that I didn't get to touch on in my presentation is that our network also has a focus on building capacity and training newer investigators in country. So I think in terms of your question about how will the research be translated in country, I think that by also helping to build that capacity, then once we have new clinical guidelines as a result of this research, it will also be able to be implemented by those newer, newly trained people in country.
Thank you. And to Dr. Brusinje, I think it's always key to get data to help guide our decision making. And I think it's really impressive the efforts that the Ministry of Health of Rwanda has gone to capture the cancer incidence in your country. What is the ministry now doing with those data? Is it impacting plans for screening or for resource allocations? I'm sorry, I think you're on mute, Dr. Brusinje.
Thank you so much. I'm not doctor, I'm Mrs. Lydia Brusinje. So maybe next time I'll be doctor, but for now I'm not doctor. Mrs. now. Okay, thank you. What I wanted to say, what I can say about that, yes, these data have now contributed the great achievement to our country. As now they have supported, we have used this data also in National Cancer Control, to the launching of the National Cancer Control, and also it is helping us to do this, to know the kind of the data we have, the most cancer that is on the top, like this cervical, cervix of cervix, so and breast cancer. It also helped us to, in these activities of screening, they have impacted us to know what we can do, and promoted this screening. We have more activities going around the country on screening of cervical cancer and detection of breast cancer. Yeah, maybe I could say about that one. It is very interesting and it is helpful to have this data on cancer incidence in Rwanda.
Yeah, it's an incredible resource. I'm sure there's a lot of questions that will follow. Again, we're using this forum to highlight these examples of excellent research, and so please reach out to your colleagues by chat or at the posters, and we'll move to the next session. Thank you so much.
Thank you.
Thank you. Yeah, so I want to again thank you both for a really great high-level overview of two complex programs. So we'll now move into our final topic area, and our final two presentations will cover survivorship and outcomes research. First, you'll hear from Dr. Sharon Lee, and finally from Dr. Antonio Bandala-Jacks.
Hello, everyone. My name is Sharon Lee, and I'm a Hematology Oncology Fellow at the Rutgers Cancer Institute of New Jersey. Today, I'd like to share an ongoing project on the Botswana-Rutgers Partnership for Health. Our case-based training program for oncologic emergencies was spearheaded by Dr. Koko Ralafala, oncologist at Princess Marina Hospital in Botswana, and a team effort in conjunction with the University of Botswana, the Rutgers Global Health Institute, and the Rutgers Cancer Institute of New Jersey. I'd like to thank everyone that took part in developing and launching this program. Oncologic emergencies contribute to a large proportion of morbidity and mortality for oncology patients worldwide. These patients present unique medical challenges due to their disease and treatment complexities, with a high risk for rapidly declining clinical status. Medical staff often do not get specific oncologic training, but will still encounter oncologic patients who tend to be their sickest. Therefore, oncologic emergencies training is important, particularly if there is high staff turnover. Our goal was to develop and implement a program to enhance timely recognition and treatment of oncologic emergencies. Due to the COVID-19 pandemic, sessions were conducted virtually with live video conferencing. A curriculum based on various oncologic emergency topics was developed in a working group between Botswana and Rutgers faculty, fellows, and staff. The focus was on practicality to reflect specific management and resources available at Princess Marina Hospital. Our target audience were all medical staff who normally care for oncology patients at Princess Marina, including medical officers, nurses, and doctors in emergency medicine, internal medicine, and other specialties, who may not have dedicated oncology training. This diverse group was targeted since multidisciplinary coordination is essential in managing oncologic emergencies. After didactic sessions were given, feedback on content was elicited through Likert scale surveys and incorporated into future sessions as the series took place. After several sessions, Botswana personnel in the audience were invited to participate in giving presentations to their peers, with guidance from the Oncology Emergencies Curriculum Working Group. In total, we had 9 live sessions with different topics given in regular intervals over several months. The topics are listed here. Each session focused on a specific topic and followed roughly the same structure, starting with pre-session teaching questions and a survey to assess underlying understanding. This was followed by cases specific to the topic, and here is an example of how cases were presented and reviewed with our participants through live chat. We then gave an overview of practical knowledge in diagnosis and management for that topic. We concluded sessions with post-session teaching questions with immediate live feedback on responses to increase retention of material. At the end of the series, a little less than half of the sessions were given by Botswana personnel, which was well received and provided mentorship and team building opportunities. We compiled analytics from our session summarized below. An average of 19 participants attended each training session. On average, our sessions consisted of about 32% nurses, 26% medical officers, 4% internal medicine residents, 16% specialists, and 21% other. In regards to results from pre- and post-session questionnaires, an average pre-session test score was 70% and increased to 82% on average in post-test scores. In regards to confidence in diagnosis of oncologic emergencies, average pre-session confidence was 38% and rose to 84% in post-session confidence. In regards to confidence in management of oncologic emergencies, average pre-session confidence was 37% and rose to 81% in post-session scores. In summary, we described the successful piloting of a case-based virtual training program in oncologic emergencies. The number of participants in our pilot was too small to make any statistically significant difference, but the pilot, developed with dynamic feedback, was well received, and data suggests a benefit to the participants with increased confidence in diagnosis, recognition, and management of oncologic emergencies. Plans are in place to create materials that can be widely distributed for the education of oncologic emergencies and expand the series to more sites within the country, most of who do not have dedicated oncology trained staff. Ultimately, we'd like to measure outcomes for oncology patients before and after implementation of the oncology emergencies curriculum. A big thank you to everyone as part of our team and grant support from Suba Berry in the Ruth Strayer Fellowship and National Center for Advancing Translational Sciences. And of course, thank you so much to the National Cancer Institute and the Symposium on Global Cancer Research for this opportunity. Thank you very much.
Good day to all of you. My name is Antonio Bandala-Jax from Mexico City's National Institute of Public Health, and our abstract is titled Survival of Breast Cancer in Women Treated under Mexico's Seguro Popular. So in the year 2003, Mexico introduced Seguro Popular, or popular insurance, a public health insurance without copays that aimed to enact universal healthcare by covering the previously uninsured population, which was almost half of Mexico's population at the time. In the year 2007, breast cancer coverage was added, and it treated a progressively higher number of patients until its dissolution. In the year 2019, President Andrés Manuel López Obrador announced the dissolution of Seguro Popular and the transition into a new health system known as INSABI, which is currently in the process of full adoption. As data from patients treated for breast cancer during all of Seguro's Popular existence became available, analysis of factors that affected survival and the program's outcomes for these patients could set base for a comparison with the new program, or INSABI. We aim to explore factors that affected survival to determine if survival was heterogeneous by state of treatment and if the program's outcomes for these patients improved as the program progressed. For this, we performed a retrospective cohort analysis with data from reimbursement claims for 57,000 breast cancer patients treated between 2007 to 2016. We then cross-linked these participants to a national mortality registry and classified them by socioeconomic and clinical characteristics. For the analysis, we calculated survival curves with the Kaplan-Meier method and created distribution figures for clinical stage as the program advanced in time. So for our results, the 5-year overall survival for the whole cohort was 73.5%. By clinical stage at diagnosis, as you can see on the table on the left, 5-year overall survivals for early stage, locally advanced, and metastatic stage were 88.9, 69.6, and 36.9% respectively. We found that factors such as age 40 or older at diagnosis resulted in higher overall survival in locally advanced and metastatic stage. Factors such as socioeconomic level decreased survival slightly only in locally advanced stage, and that tumors positive for HER2/neu receptors translated into lower survivals in stages 2B or higher. For example, here we can see that patients with HER2/neu positive tumors had a 69.4% survival, compared to 70.7% survival if they were HER2/neu negative. We evaluated survival according to year of start of treatment and found no clear improvements. For example, survival for metastatic stage was 32.8% in 2007, which increased to 37.5% in 2013. However, if we look at early and locally advanced stages at diagnosis, 5-year overall survival for early stage was 89% in 2007, which dropped to 87.7% in 2013. And 5-year OS for locally advanced in 2007 dropped from 69.5% to 68.3% in 2013. These survivals were heterogeneous according to state of treatment. In the map in the right, we show states with higher 5-year overall survivals in a darker shade of blue, and those with lower overall survivals in a wider or lighter shade of blue. So the 3 states with the best outcomes had 5-year survivals that range from 78 to 83% with no clear geographic distribution. Conversely, there were 3 states with survivals of 67%, 64%, and 56%, all of them in the south of the country. Finally, in the middle panel, we show the distribution of clinical stage according to year of beginning of treatment. So for example, as a proportion in 2007, 26% of diagnoses were made in early stage of disease and 11% were made in metastatic stage of disease. If we compare this to 2015, detection in early stage went only from 26 to 29%, while detection in metastatic stage actually rose from 11% to 13%. So in conclusion, we found no change in the distribution of clinical stage at diagnosis through the years, nor a marked improvement of overall survival as the program progressed. We also found important survival heterogeneity by state, with some states having survivals of over 80% for 5 years, and some states having survivals of under 60% for 5 years. We also find that some socio-demographic and clinical characteristics that affected survival. In conclusion, we believe that future programs should emphasize early detection screening strategies and enforce equitable standards of care among all of its providers. Thank you for your attention.
Great, thank you again. So I want to start off, we had a question in the Q&A for Dr. Lee. I see that you started responding, but I wanted to give an opportunity for you to speak to it. Someone asked, did you have palliative care providers of any level in your trainings?
Yes, and thank you everyone again for attending and viewing our session. So I also agree that palliative care providers and also personnel are extremely important in managing oncologic emergencies and involving them early on. And we did have them involved in giving one of the last sessions that we had in part of the curriculum. And we also included palliative care points within all of our oncologic emergency lectures as well.
All right,
great, thank you.
Question for Dr. Bandala-Jacks. That's really comprehensive survey. It's really quite interesting. I'm wondering if you can speculate or if you have data for understanding the state-by-state heterogeneity in the context of a federal healthcare plan.
I'm sorry, could you repeat that?
So can you speculate as to the factors that underlie the state-by-state heterogeneity? Could you attribute it to socioeconomic or there are other issues involved?
We mostly speculate that those states with a higher overall survival is because patients have better access to treatment facilities and because hospitals are better equipped for treating these kinds of patients. It might be related not only to hospital volume, but also to availability of resources and patient access. On the other side, for example, those states with the lowest overall survivals have the highest percentage of indigenous population, have very few tertiary or secondary level hospitals, and it is more difficult for patients to have access to treatment facilities.
So in the context of having a national health plan, are there steps that can be taken to try to alleviate some of these region-specific challenges?
We mostly emphasize that the goal of all of this is to go on early detection strategies, as it has been previously mentioned in the resilience panel. So we speculate that if we have better screening programs and patients had more access to screening programs, we would detect more patients in earlier stage rather than late stage, and this would translate into higher survivals. So we will see how the new program or in SAVI will handle this early detection stages, which is what we did not find to happen in the previous program.
Thank you. I have a quick question for Dr. Lee. So at Princess Marina, in addition to sort of making a difference in competency through the education sessions, what did you see a difference in outcomes of kind of morbidity and mortality associated with oncologic emergencies?
Yeah, I think that's a great question, and certainly something that we're interested in measuring in the future. Our curriculum was just launched this fall, and so it's a little early at this point, but in general, when we got feedback from the medical officers and nurses who attended, they definitely felt that they learned a lot from each session and could apply it directly to their practice.
All right, thank you both so much for your excellent presentations. So I think we have about 2.5 minutes left in our session here, and I wanted to give a quick wrap up and say again, thank you so much to all of our presenters. Thank you to the audience for engaging conversation that I hope will continue. Again, we tried to, we have just seen presentations from around the globe across the spectrum of cancer research. And so again, thank you so much for the meeting organizers and for the presenters for such a dynamic session. And we hope to see you all back tomorrow at 8 a.m. Eastern Standard Time to continue this really exciting symposium.